Okay, so within a 10 seconds, we will have to the attendance.
Yeah. Record the proceedings.
Yes, sir.
Start recording then.
So, sir, it's 3, 2, 1. Over to you, sir. Now you can start the session, sir.
Good morning
Please start
from FOGSI ICOG and you are muted, sir.
Yeah. Unmute.
Ashok sir, you are muted, sir.
Just 1 minute. 1 minute. I'm unmuted now. Am I audible?
Yes, yeah, yeah.
Yeah.
Please start recording also.
So, good morning from FOGSI ICOG Mumbai, and we are here on second Sunday of the month of March 2025 for another edition of FOGSI ICOG PG Clinic. And this time we are having our program on very interesting topic. And at the outset, we are thankful to FOGSI ICOG President Dr. Sunita Tendulwarkar and ICOG Chairperson Dr. Parag Biniwala for having support and confidence in us. And with their permission, we are able to continue this program in the 4th year. And I hope with our program, all the students as well as teachers are having lot of updation in their knowledge. So before we proceed further, I request our chairperson, Dr. Parag Biniwala, to say a few words.
Thank you, Dr. Ashok. Good morning, all. I bring greetings from ICOG, and it's indeed a pleasure to be joining this program from a remote place called Akluz. I must compliment the 3 coordinators of this activity, Dr. Ashok Kumar, Dr. Ashish Mukhopadhyay, and Dr. Hafizur Rahman. Special thanks to the 2 teachers who are going to teach our students today, Dr. Hiralal Konar, past chairperson of ICOG, and Dr. Lata from JIPMER. Thank you all the examiners, Dr. Ashish, Dr. Bijal Patel, Dr. Devabrata Barman, Dr. Ranjit Mondal, and Dr. Kamana Datta for sparing your time. And thank you, Dr. Ashok Padi, for taking up responsibility of case presentation by 2 of your students. So as usual, I'm sure this will be a good learning experience for all of us. My best wishes for the program and happy learning. I'm happy to welcome Dr. Sunita Tendulwarkar, the president of FOGSI. Welcome, Sunita. And we would listen to a word of wisdom from you.
Thank you. Thank you, Parag. And I need to congratulate ICOG for doing a wonderful job in our academics. I think we are lucky to have such teachers of the repute who are always there. Ashish, last time I saw your pelvis leke, the way you were showing the occipital anterior, occipital posterior, I felt like during our residency, I wish we would have got such a teaching experience. Today, students are lucky that they get everything on platter. Hiralal Konar, Hafizur, Ashok, you are doing amazing job. And Parag, keep on doing. And another thing yesterday, I just want to tell because we forget later, Vice Chancellor from MUH was there. And I told her, we have an academic college and we'll be happy to get, affiliated with the university, since our college is doing amazing job with more than 3,000, 4,000 fellows. So she's requested, she said, yes, amazingly, we will do something. I don't know whether it will be only Maharashtra or it will be over all India. Parag, she is going to give me the details, and we need to dedicate 2 people to do that job, because there is a lot of paperwork and other things which are needed, and you are also busy, but give someone who are experienced, who are HODs, the full-timer, because she specifically said, I want HODs. And Ashish, believe me, you came in front of me. Ashish and Hafizur, if they join together, they can definitely, because there is a lot of paperwork which will be need. But Parag, if we can do in this year, the affiliation with this, she is more than open and she wish to do that. Let's take the call, our ICOG to another level.
That's a great news, Sunita. I happen to know her very well.
Yes,
fact,
she was in Pune FMC, na?
uh,
Yeah,
at our annual POJ's conference. So
yes.
I think it's a wonderful step that you've taken, and let's all take it ahead.
And she was during my vice presidency, na, she was involved in one of the social project. Me, Charu, and she, we did a fantastic job together. She was remembering all that. And yesterday I told her, she has given me a card which has a number of that college. I'll just pass on immediately the photographs and all. It is at home, but I'll pass on to you. It has a local numbers of the universities. It has her mobile number of that university and all the mail ID. And I'm sure you will take it ahead. Definitely next Sunday evening, I'm leaving for Dublin, but next Sunday we meet it. Thank you.
I think,
So-
Sunita, you are always full of innovation, innovative ideas, and very good thoughts. It's a very good thought that you have generated out of yourself. And I think that it can be done. Maybe there are some paperwork involved. So let us prepare a module for a common presentation.
Absolutely. She wants these modules and all. So what I will do, Ashish, is I will share. Now I'm in my consulting, because night I'm leaving for Dublin. Whole day I'm working here. But the card is at home. I will give you at any cost without fail her all numbers. And with Dr. Parag Biniwale, you take up this project, and I'm sure within 3 to 6 months of a hard work, we'll get the university affiliation with FOGSI. Because yesterday when she was talking about vice chancellor and university, I felt this is a golden opportunity for us. The ICOG is doing such amazing work. Let's join. And she's very pro. She's a pediatrician. So she is very much interested. We have done the baseline work.
Clinical medicine, right?
We need people like you, along with Parag Biniwale, to take it ahead. Thank you so much. Your teaching.
Madam, more what to add. Since the inception during my tenure, also 2013, we thought about this going at the university. It's a good dream that you have made it, and if we make it, definitely it will be a well ahead step for the ICOG. Thank you
Let
so much.
one professor, since Ashish is there and Hafizur is there and Parag is there, I think let Parag take care, and three of you decide how to take it further. Okay? My job was to do the job and convey to the ICOG.
Brilliant idea, I
Great.
must say.
Great.
Very good
Thank
idea. And let's move ahead with this idea.
Thank you.
Thank you, madam, for your kind words, encouragement, and your efforts in making ICOG more internationally recognized platform. So thank you so much, and it is a good initiative on your part, and we'll be definitely.
Since Parag knows her also,
Yeah.
things will become very well. I thought it is a ICOG chairperson. I need to just pass on that we have preliminary discussion, and this chairperson will take ahead with the professors.
Yes, madam. Thank you very much, madam. And thank you for sparing your valuable time today for us in giving us a word of wisdom also. Thank you very much. So we go ahead with our program. We welcome our faculty and our students today. The topics today are on doll and dummy, as we always do in our program. And today, Dr. Hiralal Konar will demonstrate breach, how to deliver a breach, and what are the mechanisms and maneuvers involved in that. And then we have a case discussion on CA cervix. And after that, in the skill-based learning, we'll be having a discussion on opening and closing of the abdomen at the time of cesarean. So these are the important things which we have to learn today. and we have our faculty and students, and I welcome all of you as an expert teacher, and thank you at the beginning only for your sparing your valuable time for ICOG. Thank you very much. Now I request Dr. Ashish Mukhopadhyay sir to say a few words, and then Dr. Hafizur Rahman will take over and introduce the faculty. Thank you very much.
Yes, thank you, Dr. Ashok Kumar. And 3.5 years and continuing and counting, the ICOG is marching ahead with the idea of spreading knowledge, awareness, and exam orientation for the PG students, which I think is a very, very noble attempt because, ICOG has been actively involved in teaching from its inception. But as you must have noticed that ICOG has always evolved itself, changed itself according to the modern NFC criteria. And that is the best thing about it, with the guidance of Professor Ashok Kumar, Dr. Parag Biniwale, and Dr. Hafizur Rahman. I think every day we are evolving our thoughts, we are changing our thoughts, and we wish to do it according to the NMC guidelines so that no ifs and buts in the minds of the students. I think that is the in thing about this PG teaching program, curriculum. And recently we have added a quiz program also, which will add interest to the students much more, because that learning, and you must have noticed that the theme subject of one particular PG clinic is the theme subject of the quiz also. So I think that it will allow the students to go in deep into the learning process, and it will do wonders for them, not only for the exam, but also for their future lives. Thank you very much, all of you. Now, Hafiz, to take over and introduce the faculties, please.
Thank you so much, Ashish sir. I'd like to express my sincere thanks to Sanita madam for joining and encouraging us. Actually, it's really boasting that is ma'am has given her valuable time to encourage us with what we are doing for the last 3.5 years, as Ashish sir said. I must express thank you to Parag Binwale sir, because sir has been very much, because many times when I am doing other than sir reminds Hafiz how is the program and everything is being planned. So thank you so much. And of course, Ashok sir and Ashish sir, because all of you have been very much supportive in having continuing this program. And what more inspires me is seeing the students. Many times I am getting their queries. They want to have different ideas. They also share their ideas. And of late, they have interest generated in this quiz also. So I am sure this is helping them in preparing their topic much better way. So I'd not like to waste much more time, so we can start our session. So the first session, as from the request from the students, that is Dr. Hiralal Kunar, sir is former professor and HOD at AGMC and is a well-known faculty. So sir will have demonstration on assisted vaginal bridge delivery and various maneuvers, because students always think in bridge there will be difficulty. So I am sure sir will make easy for them for the various maneuvers. Then we have got another important topic actually for the case discussion, which is actually the theme topic for these days. So we have got student from Acharya Harihar Postgraduate Institute of Cancer. So they will be presenting a case on cancer cervix. Dr. Anesha Pal and Dr. Anirban Talukdar, both of them are second year MCA student, and they have been guided by Dr. Bhaigalakshmi Nayak madam and Dr. Ashok Kumar Padi, who is associate professor at the same institution. Now we have got a galaxy of faculties who are actually expert in this field. So I am sure this is going to be those students who are presenting, as well as all the students, those who will be actually observing and will give them lots of input on this important topic. So Dr. Ashish Kumar Mukhopadhyay sir is principal and professor at CSS College of OBGYN. Sir is always there in guiding us. Then we have Dr. Bijal Manish Patel. Madam is professor and head of gynec oncology at the Gujarat Cancer and Research Institute, Ahmedabad. Then you have got another expert faculty in the oncology, Dr. Devabrata Burman. Sir is professor and head at Dr. B. Borua Cancer Institute, Guwahati. Then we have another eminent expert, Dr. Ranajit Mandal. Sir is professor and head at gynec oncology at Chittaranjan National Cancer Institute, Kolkata. Then we have Dr. Kamna Datta. So Madam is professor at Atal Bihari Vajpayee Institute of Medical Sciences and Dr. Ram Manohar Lohia Hospital. So they will be taking up on this case. Followed by, we'll have Dr. Lata Chaturbadala Madam will have another interesting and requesting topic from the students. That is different texting and opening and closing. The techniques will be there. So Madam is professor at Jawaharlal Nehru Institute of Postgraduate Medical Education and Research at Puducherry. And then we'll have the quiz on the theme topic. So I will not have much time. So I'd like to request for the first session, Konar sir, to just share your, if you need to want to take the session over, and please start having your session. Over to you, Konar sir.
Thank you very much, Professor Hafiz. At the outset, I express my sincere thanks to FOGSI, ICOG, having this opportunity to take part in the academic program. Dr. Sunita Tandulkar, the President FOGSI, Dr. Parag, Chairman ICOG, Professor Ashok Kumar, the Vice Chairman, Dr. Suvarna Khadilkar, the Secretary General, as well as Sarita, the Secretary General of ICOG. And obviously, it is an opportunity to talk about this. My topic this morning that has been allotted is that the fetal skull and the maternal pelvis. And the second topic comes on demonstrations of assisted vaginal bridge delivery and the various maneuvers. You see, one topic is common that has been discussed often now and then. So maybe that I would cover those two topics very shortly.
Excuse me, sir. Excuse me, sir. Sir, it is only the one topic. Actually, this is the heading of fetal pelvis, skull and maternal pelvis is the heading of our series. Under this, you are only having today the breech part. So please concentrate only on breech.
Right. That's fine. So I had the impression that probably we need to talk about a little bit about the fetal skull, and so that
no, sir. No, sir. No. Just focus on breech only.
Right, you are. So basically, the breech and the breech maneuvers and assisted vaginal bridge delivery, my interest also with this topic, this is a sort of obstetric practice that is declining now. This is one. And the art of delivery, selection of the case, and that of the other maneuvers that are related to the assisted vaginal bridge delivery, less commonly observed. My interest to start with, you see, when I was a house surgeon, I remember that the evening, month of July, that as a house surgeon, I was entering the labor ward night duty. Day shift has gone. I was about to join the night duty. I entered the labor ward and I could see 3 patients, torrential rain, the day shift, doctors had gone, senior doctors gone, night shifts, we are waiting. I am the house surgeon. I could see 3-4 patients on the table, and one of them asked me for her pain. I examined her. I could see she is nearly fully dilated and she is a case of breech. You imagine, as a house surgeon, I informed this event to the senior nursing staff, midwife. She said, why you are worried? I said, yes, it is a breech case. So that's the reason I am worried. And she assured me, you know, that the mechanisms and things that I know, theoretically I know, because I had the opportunity of teaching the students, the interns, about these different maneuvers as a house surgeon. So I was conversant with that. And they said, that's no problem. She said, you follow what I will tell you. There should not be any problem. In fact, in reality, rather, I did it and I could make the delivery successfully without any injury, neither to the mother nor to the fetus in the new world. So that's my experience. Another experience that I had during my stay in England, you know, as a registered, when I was working, mostly I worked that time in that of the northern part of the England. One patient from that of the border county came down to our hospital with my name, that she wants breech. She had the breech presentation, nearly term. She wants vaginal breech delivery. Doctor over at the border county hospital told that no way, we are going to go for that. We will deliver by cesarean section. She came down. In fact, I counseled her. I talked to her all the way, assessment, all this baby, fetus, and that of the pros and cons. And ultimately, we decided and she consented. Examination point, there was nothing such contraindication for assisted vaginal breech delivery. And then went into spontaneous labor. With my effort, we could deliver her successfully and safely. These are the reasons, but these days we could rarely see the place of assisted vaginal breech delivery. More or less, this is the practice of these days to go for cesarean section almost all the cases. So unless the woman comes in the nearly she is about to deliver. Otherwise, most of the cases are going delivery. Now coming to the situations of the bridge delivery, to talk about little bit about the anatomy and that of the physiology. Bridge delivery, as you know, we call it when the podalic pole comes to the lower pole of the uterus and the lie is longitudinal. So this is the bridge presentation, and it could be basically we need to have the common understandings of the male presentation and especially that of the bridge to have the understanding and assessment of the case, whether we would be able to deliver her successfully vaginally, or she is a case for cesarean section, or alternatively, she is a case for external cephalic version and followed by bridge delivery, by cephalic delivery. So these are the areas. That's the reason we need to know as a clinician complete assessment of the baby. Now, bridge, we know that is a complete bridge, meaning that the flex spines, flex hip, flex legs, this is one complete bridge. Another is type of the incomplete bridge. Incomplete bridge means that the legs are extended, maybe the spine is extended, maybe the head is extended. So this is the incomplete bridge. That could be the extended legs, or sometimes the foot link presentation, or sometimes the knee presentation. So these are the different types of bridge presentation that makes the bridge incomplete bridge. So complete bridge, incomplete bridge. Again, then bridge could be associated with complications. Complications meaning that apart from the obstetric complications, there could be some other medical complications like preeclampsia. So complicated bridge or uncomplicated bridge. So this way we go by the different areas of bridge presentation, and that these are all essential for that of the making the decision that I always stressing, making the decision for the delivery. Now, for the diagnosis of bridge, you see, we by and large, we the clinician go by clinically. Clinically, the assessment of diagnosis of bridge presentation is clinically by assessment of the general health of the mother and then obstetric examination by the different groups. As I have told you, keeping in mind the possibility of the complete bridge or that of the bridge with extended legs, that could be parallelly, that could be diagnosed clinically to some extent, not that 100%. Again, we need to go for some investigational methods to confirm the diagnosis. To talk about all of us that of the clinical assessment, clinical diagnosis of bridge presentation, the fundal height, fundal grip. Fundal grip, if you are a bit careful, keeping in mind that you feel the hard globular mass in a case of flex bridge, and in case of incomplete bridge or bridge with extended legs, you feel that of the foot links are there around the head. So some amount of irregularity around the head instead of complete round firm globular mass in a complete bridge. So this is the difference. Obviously, the lateral grips, as we know that of the broad curved soft mass on the one side, the back, and other side is the irregular limbs could be there. And now the pelvic grip, in case of the complete bridge, you feel the conical mass around the limbs side, and especially bridge with extended legs, you feel the totally conically mass, and sometimes there could be the bridge is engaged, especially in case of bridge extended legs, often there is engagement. Now, coming to the, once the diagnosis is confirmed, definitely we always go by the confirmation of diagnosis, and essentially we need to know for making the decision of delivery, we need to know the other components of the clinical diagnosis. So that is the ultrasonography. What the additional help we get with the ultrasonography? Definitely the different points like bridge, it is the flex bridge or bridge with extended legs or knee presentation or foot link presentation. Is the head extended? Amount of liquor? Where is the placenta? Is there anything, an anomaly? So all sorts of information we could get by the ultrasonography. So once we make the diagnosis clinically, definitely we go by the confirmation of diagnosis as well as for the other information with that of the sonography. And finally, we need to know two more important issues. One is that of the attitude of the head. Is the head flexed or is the head extended? Obviously, that makes a lot of decision-making parameters. And now then, estimated weight of the fetus. These days, there have been clear guidelines regarding the estimated weight of the fetus, and then that makes the decision whether you should go for the abdominal delivery or the rather elective cesarean section, or that of this assisted vaginal bridge delivery. So these are the situations that we need to go for. Now coming to our main area of attention, as I have told you, these days bridge delivery has almost been out of practice. Most of the institutes, especially the teaching institutes and that of the government hospitals, as well as in the personal clinics also, more or less all the bridges are being delivered by abdominal delivery. You know, that means what is the concern? Concern is the complications to the mother and mainly that of the baby and the newborn arising out of assisted vaginal bridge delivery. Now, think of the complications. What are the complications? Yes, there are complications are there, and that may end up with injury. Injury to the newborn or the neonate in terms of intracranial hemorrhage, because during the assisted vaginal bridge delivery, the aftercoming head comes at the end of the delivery, and effect of compression, decompressions, and the maneuvers, or that there may be injury, that the tentorial tear, intracranial hemorrhage could be there. There could be some fractures of the bones, like clavicular fracture or the humerus fracture, shoulder dislocation, or that the hip all complications, femur fracture could be there. Again, then other visceral injuries are there, like liver injury, spleen injury, adrenal injury, all have been mentioned. Sternomastoid humor, all complications have been mentioned. Now, question is, should we consider this pathway or mode of delivery which is so risky, or we should think of something else? Obviously, safe alternative goes that of the cesarean delivery. Now, let us discuss about the current research. You see, if you look back, the Green Top Guidelines, Royal College, to my mind, it is in 2017. Let us consider the relative risk. In ideal surroundings, the relative risk of perinatal mortality and morbidity. Now, consider that of the all cesarean, newborn of all cesarean delivery, first group. Second, that of the vaginal cephalic presentation delivery, fetus with cephalic presentations and vaginal delivery. And third group is that of the breech presentation vaginal delivery. Now, the morbidity has been explained in terms of 0.5, 1, and 2, meaning that assisted vaginal bridge delivery has got a potential risk of 2 compared to that of the 0.5 delivery by cesarean section and 1 cephalic vaginal delivery of the vertex presentation. That means there is marginally increase in the morbidity in case of assisted vaginal bridge delivery. Now, question comes on analysis, is it so, or can we reduce this morbidity and what could be the way? Now there comes that of the parameters that has been analyzed in most of the world centers, that how it could be avoided. You see, main concern was that of the, I believe most of us would be, especially that of the postgraduates, you would be knowing there was a paper in around 2000 that came in Lancet. That paper changed the concept and the practice of assisted vaginal bridge delivery or bridge delivery altogether throughout the globe. It came in the Lancet 2000, talking about the research work, you see, randomized control trial. It was a randomized control trial in 126 countries, 121 centers, considering 2,088 women. Now let us listen carefully. 2,088 women from 121 centers and 120 countries. So this was the randomized control trial, and the authors proved that improvement of the perinatal mortality from 1.3% to 0.3% and severe neonatal morbidity from 5% to 1%, statistically significant reduction in the morbidity by doing the cesarean section. Obviously, there was no significant difference in the maternal mortality and morbidity. This is the randomized control trial, Lancet paper, that 2000 that changed the world practice of assisted vaginal bridge delivery in favor of cesarean section. Obviously, you see years gone by, this paper didn't escape the criticism. Griezmann 2006, this article came in American Journal, 5 years of the term bridge trial. This paper was, this 2000 Lancet paper was criticized, and opinion was 5 years to the term bridge trial, the rise and fall of a randomized control trial. And with this trial and world over, again, there is change in the concept of assisted vaginal bridge delivery. Basically, if we look back into the European world, the Primordial study concluded vaginal bridge delivery singleton fetus with bridge presentation at term would be a safe option. You see, this is the another paper that control trial established that there is safety provided the case selection is there for that of the assisted vaginal bridge delivery. So this is the concept that changed, and with that, world over, that is the, especially the European countries, Norway, Finland, France, Netherlands, everywhere, the assisted vaginal bridge delivery is in practice, obviously, in a selected case. Limitations of term bridge trial led planned vaginal delivery continued in Scandinavia, France, and Netherlands. This is the current scenario now. So we should, maybe we need to, Indian colleges need to revise this concept of assisted vaginal bridge delivery, provided the areas of weakness, meaning that what I was talking to you, selection of the case, expertise, experienced person conducting the delivery with the requirements fulfilled, meaning that the institute also available resources, the time of need, even there is need of cesarean sections at the time of bridge delivery, that should be available. So there are certain limitations that we should improve, and we should go for the assisted vaginal bridge delivery. Now then, if we consider that of the assisted vaginal bridge delivery, clinically, as a clinician, I would say not all cases, definitely, or not all cases could be considered for assisted vaginal bridge delivery. Then consider who were the cases. Cases means that of the, if the patient has got, woman has got some obstetric complications like antepartum hemorrhage, or that of the preeclampsia, or the baby is big, meaning that 3.5 it is stated, maybe that we consider 3 kg. So there are certain reasons, certain selection criteria of the cases where we should limit our selection for that of the assisted vaginal bridge delivery, then in favor of that of the, rather than not doing that of the cesarean section. Again, then there are cases for that of the cesarean section that I have told you, more than estimated, or elderly woman, the pelvis is not that adequate. So those are the clean-cut cases where we can go for the cesarean delivery, and there could be cases there where we can go for assisted vaginal bridge delivery. Now, there is a third alternative. Making the delivery of the bridge presentation woman, either the cesarean that we have discussed in fair details, what we should do really. Otherwise, we should go for the assisted vaginal bridge delivery, provided the skill of obstetrician is there, all the parameters are fulfilled, all the requirements should be available, including the institute resources and the senior presence of the senior person. That was not done in the term bridge trial. Now then, what is the third alternative? Should we go for the external cephalic version? There is an area of bridge management, place of external cephalic version. What is this? Probably, I don't know, during my student period, I have seen our teachers to do that of the external cephalic version. Basically, I'm talking of nearly 20-25 years now. I have seen good old teachers doing even in the OPD. And then around 32-34 weeks, now then assisted external cephalic version has got certain limitations, has got certain guidelines to perform it, meaning that it has been recommended to go for 36 weeks onwards. Because earlier you do external cephalic version, there is a risk for reversion. We raised the issue to our teachers that time, said this is 32 weeks. If it reverse again, sir used to say, well, we'll do it again, no problem. So selection, moreover, most of the colleges has recommended the external cephalic version preferably to be done at 36 weeks, 37 weeks, and it is to be done in the labor ward complex, so that in case of any emergency, the mother could be delivered, and there should not be any problem with the survival of the perinatal, improvement of the perinatal outcome. So 36 weeks, 37 weeks, external cephalic version, complications, there could be complications. Common complications may be that the premature rupture of the membrane, or cord entanglement, or separation of the placenta, or some non-reassuring fetal status. So these are the areas, that may arise as a complications of external cephalic version. But most of the centers, they have recommended, or they have opined that the success of external cephalic version to the extent of 65% provided in a selected case. So there is a group of case selection again. Then what could be the case selection? Case selections means that average size betas, meaning that they are telling less than 3.5 kilo. Maybe we should consider 3 and less. So external 36 weeks, labor ward complex, keeping everything ready if there is a need. So these are the prerequisites that should be done. If the mother has got any complications like preeclampsia, oligohydramnios, hyperextended head, these cases are not suitable, or overweight, more than 3.5 kg. These cases are not recommended for external version. Though external version has got the good success rate, selection of the case is again important. So if this case is considered for the external version and we succeed that of this cephalic conversion to the cephalic presentation, rectification to cephalic presentation, what are the advantages we get? We reduce the incidence of breech presentation. We reduce the incidence of assisted vaginal breech delivery. We reduce the incidence of cesarean section. So external cephalic version is an obstetrics art and skill that we are forgetting. I don't know, because of the fear, definitely there is a fear, but there is situation for the open discussion, learning, practice. Honestly speaking, most of the countries in Europe, my subject of interest is so deep. I looked around the different European centers, like that I told you, the Norway, Finland. There are breech centers. There are breech clinics, meaning that the regional center of breech clinic, all the cases of breech could be referred to that center so that the cases are appropriately selected, needful investigations are done, and the appropriate management protocol is guided, so that unnecessarily we jump onto the cesarean delivery once we see a single case of breech presentation. The other day, that I think Professor Parag Biniwale is there or not. The other day in the ICOG conference in Pune, in a discussion of management of mother with prior cesarean delivery, should we consider for the cesarean vaginal delivery, or should we go for the repeat cesarean section? There was a discussion, then opinion. I involved myself there also in the discussion. Probably, ultimately, we concluded that yes, there should be. I raised this issue of breech clinic. So everybody agreed to that and thought that why not we can go for the mode of delivery in women with prior single cesarean delivery for the considerations of repeat cesarean section or in favor of the vaginal delivery. So there is a concept, because awareness is there. Days are gone, then we would not consider the patient herself or the relatives. We always consider the patient's relatives, patients herself, pros and cons, provided with the resources are kept ready, meaning that of the proper assessment of the case, resources of immediate emergency obstetrics management is possible, and all resources are available, senior persons should be available. What is always there, why not we can think of this and consider for this assisted vaginal breech delivery, or in a selected case safely. Now coming to our, then we have talked to that external persons, we have considered the cases for the repeat cesarean sections in breech presentation. Coming back to that, we have selected the cases of assisted vaginal breech delivery. Now then, what are the criteria to be fulfilled if we consider that of the assisted vaginal breech delivery? Obviously, standard idea that we practice, that the regular antenatal visit, maybe we will admit her in earlier, or we will request her to attend the clinic with the spontaneous onset of labor pain if everything is fine. With all investigations, baby is fine to be healthy, well grown. And then once she admits in this labor, or if she is electively admitted and she is allowed to go for the spontaneous onset of labor, you see, regarding the spontaneous onset of labor and that of the labor induction, it will be appearing strange to all of us. My interest is because since with my house surgeonships with the breech, that I worked in England, I used to go for this assisted vaginal breech delivery with all the criteria fulfilled, everything, all resources are there, no problem. One of my consultant from Greece, he said, why not you go for the induction of labor? I looked at him, say, induction of labor in breech cases, breech presentation, I haven't got no experience of doing such, I have not heard of it. He said, nothing to worry about. You do, I am there. He was very fond of assisted vaginal breech delivery, even that of the induction of labor. And I have seen in a well-selected case with experience and expertise, probably with all the resources available, probably there is no such selectively. Yes, selectively it could be done. Now coming to our back discussion, that once that of the criteria fulfilled, what we should do? Spontaneous onset of labor? Well, in that case, we always alert our team, senior obstetrician, anesthesiologists, neonatologists, and the resources, meaning that of the labor ward, theater resources available, labor ward, meaning that the instruments for that of the making episiotomy, pair of forceps. I have Professor Mukherjee will see that I have got these forceps also, to demonstrate you for the upcoming head forceps delivery. So once it is there, then probably allow her to go on the spontaneous onset of labor, monitoring uterine contractions and the progress of labor. Obviously, electronic fetal monitoring. Probably, if the resources permit, it is better to go for the electronic fetal monitoring to assess the reassuring pattern of the fetal heart rate and everything. When, as you have already have the information, so the breech with flex legs and breech with extended legs, depending on that, if this goes into labor, analgesia, epidural, probably the anesthesia, analgesia or anesthesia could be used depending on the situation, and that of this neonatologist should be made available. All the episiotomy set is there, and we proceed for that of the assisted vaginal breech delivery. Basic principles of assisted vaginal breech delivery to tell you, nothing rush, nothing to worry about, nothing to rush and do something wrong. Never pull. Main tricks is that what our teacher has said, never pull, but push from above. Always keep the back anterior and assist the process of delivery as it is. So flex breech, once she is in labor, perineum is distended, and make some episiotomy. Episiotomy has got some benefits, meaning that intravaginal manipulation, sometimes we need to go for the forceps for the aftercoming head of delivery, or sometimes we need to release the compressions of the umbilical cord, sometimes to deviate the umbilical cord toward the one side. So there are many ways of doing things. So episiotomy probably is needed. And then in case of flex breech presentations, once the sacrum comes down, the buttocks comes down, footlings could be seen. We wait. I have got the video. Time permits, I will show you that we release the footlings and the legs are born. And then, or in case of the extended legs, we wait till the popliteal fossa is visible. And once it is there, we, depending on the need, syntocinon could be added. There is no such contraindications for syntocinon if you feel contractions to be augmented. So we...
Dr. Kunar, I'm very sorry to interrupt you. If it will be very nice if you kindly show these in a dummy doll, because that's a session in a dummy doll and pelvis, and students will be very much benefited if you can show these mechanisms of assisted breech delivery with the help of a dummy doll. And second thing is that we have the constant of time also. Very sorry to say that you have only 5-6 minutes left now. After that, we have to go to the next session. Please, kindly.
Sir, thank you very much. I was told 40 minutes time. I don't know how much minutes I have crossed over. And that I was going to tell you that, you see, I have got the pelvis. You know that I have got the fetal skull. You can see this. I have got these two pairs of forceps for that of delivery of the aftercoming head. I could not get that of the doll. I think you would be the best person to tell us why this doll is vanishing in our institutes, because probably the reason that we are not that much having the inclination towards the go for the assisted vaginal breech delivery and doll to show how the baby is lifted up. So this is the difficulty for me.
So whatever resources you have, sir, kindly finish within time, because we have to go for the next session also.
Have I crossed the 40 minutes? Anyhow, I have nearly to the end of this presentation. Now then, what I will do, so this popliteal fossa is visible, and then in a way of flexion and abduction, we release the legs. So once the legs are released, we cover the baby with a warm towel, and then what we do, that of this, see the umbilical cord, we push the umbilical cord to one side to avoid direct compression towards the sacral bay. And then we look for the inferior angle of the scapula. Inferior angle of the, I am sorry, Professor Mukherjee, that I searched for the doll. I couldn't get it because you know that the reason probably if we start practice, probably it will come back. So I couldn't get anywhere in the medical colleges. I think you will be happy, you will be smiling, but I am very sorry for this. So inferior angle of the scapula, vertebral borders of the scapula, And if they are parallel, that means arms are flexed, nothing to worry about. We wait till the axilla is visible, and then what we do, once the elbow is visible, putting our hands over the elbow, pull down the arms one to another, and always keep the back anterior, and maybe the turning the baby one side, release the arms, and then other side, release the other arms, and then the situation comes the after coming head. Obviously, as you know, this is the most crucial part, and most experience is needed for that of the delivery of the after coming head. By and large, after coming head, it is a matter of practice. Mannequins, doll, all these are needed under the supervision of the senior persons, how to do it. After coming head could be delivered by that of the forceps. Forceps, that's when I have brought the forceps. What is done that the baby is covered with the dry towel. Now the baby is lifted up with this with the trunk a little bit above, and the forceps blades are applied from down below. Forceps blades, you see, as usual, the same that of the long cut forceps, placing the palm over the left side pelvis. Left blade is applied first under guidance of the fingers. Blade goes there, baby is lifted up, and then left blade followed by that of the right blade, and the blades are articulated, locked. You see the lock is there, and then the screw may or may not, because it is a very short procedure, and then gentle tractions. Usually the delivery time between the trunk, buttocks to that of the after coming head is 5 to 10 minutes. And from umbilicus to the mouth is that of the 5 to 7 minutes. So by and large, within the short period of time with skill and maneuvers, we have to deliver the after coming head. Once the blades are applied and pulled down, the face comes down, sucking starts, and the head is delivered. If we go for that of the assisted vaginal and the after coming head delivery, that of the shoulder traction and the malar flexions and the shoulder traction, the maneuver is that the same. The baby is placed on the left supinated forearm. You see forearm, baby is placed over there, arms are on either side. Then with the right hand, we place 3 fingers, the middle finger over the occiput, the ring and the little fingers over the shoulder, and the index on the other shoulder, left shoulder, and then maintaining flexion and the traction, we deliver the after coming head. So this is the, though it is known as the originally jaw flexion, it is now replaced with the malar flexion and shoulder traction. So this is the Mauritius Olivet technique. Or we go what the Bun Marshall method. Bun Marshall method, not commonly practiced, but I have seen our teacher doing this Bun Marshall method. Baby is allowed to, once the trunk is born, baby is allowed to hang by its own weight till the hair margin is visible. Then we grasp the legs, foot links at the 3 fingers, middle finger in between, ring and the index fingers on either side, and maintaining a steady traction, the trunk is lifted up towards the mother's abdomen. So head is gradually born by the chin, then face, the nose and the brow, and the trunk is lowered down, so the head is born. So this is the delivery of the after coming head, and skillful maneuvers to practice it under supervision. Obviously, as I have told you, it needs practice, assessment of the case. So overall, it is the assessment of the case, selection of the case for the assisted vaginal based delivery, in keeping in mind the other situations of cesarean delivery or that of the Schneckerlich version, and then delivery, especially delivery of the after coming head, with more importance of different procedures that one is conversant. So this is one, and maneuvers, complications that may be needed in a situation of extended arms. As I have told you, once the trunk is born, we look for the inferior angle of the scapula and the vertebral border of the scapula. If there is a winging of the scapula, that means arms are extended. Arms are extended, meaning that that could be a difficulty. So there is a procedure called love set maneuver. By and large, this situation is rare. So love set procedure, where the baby is holding the femoropelvic grip, usually under analgesia or that of anesthesia, may not be needed all the time. So rotating the baby towards the one side, 180 degree, holding the baby, the anterior shoulder under the symphysis pubis, posterior shoulder in the sacral hollow. This is the anatomical relationship if it is the under the symphysis pubis and the sacral hollow. If we rotate the baby by 180 degree, 90 and 90, the posterior shoulder comes anteriorly beneath the symphysis pubis. So anterior shoulder, posterior shoulder is born. Rotate in the reverse direction, anterior shoulder is born. So this is the problem to overcome love set maneuver for the arms, extended arms. So this is one. I would like to show you the video if time permits.
Sir, approximately what duration is the video?
Minimum 3 minutes maximum.
Okay, 3 minutes is okay, but we have to start the second session.
Sure, sir. In fact, if I get that video, so I will be.
Okay, sir, you look for it, and thank you very much that in spite of having the predicament of not having the dummy doll, you have managed the assisted bridge delivery so well. Thank you very much for that. In the meantime, that you look for the video,
Sure,
we
sure.
will start the next session, sir, please, if you don't mind. Okay,
Thank you.
to save time, Our
Sure.
next session today, our theme subject is carcinoma cervix. So I would like to invite Acharya Harihar Postgraduate Institute of Cancer, Cuttack, and the presenters will be, on a case of cancer cervix, presenter will be Dr. Annesha Pal and Dr. Anirban Talukdar. Both are second year PGs there. And the coordinator faculty is Dr. Ashok Kumar Padhi. We all know the faculty, and we'll introduce the student also. And faculties for this session, apart from myself, will be Dr. Vijal Manish Patel, Professor and Head, Gynec Oncology, the Gujarat Cancer and Research Institute. Then Dr. Debabrata Barman, Professor and Head, Gynec Oncology, Dr. Bhuvaneshwar Borua Cancer Institute, or Guwahati, Assam. Dr. Ranojit Mondal, Professor and Head at Gynec Oncology, Chittaranjan National Cancer Institute. And Dr. Kamna Datta, Professor Atal Bihari Bajpayee, Institute of Medical Sciences, and Dr. Ram Manohar Lohia Hospital, New Delhi. So could I have the Annesa and Anirban on the screen, please? Are you there? Yes, Annesha, I can see, and Anirban is also there. So, and I invite the faculty cordially to examine this case. They will present the case, and that will be followed by the crossing by our learned examiners. So,
Yes,
Annesha, could you share your screen now? Yes, Hafiz, do you want to say something?
No, sir, it's fine, sir. I just like to request them and to the host team to pin them so that they are on the screen, the presenting students.
Absolutely.
And
absolutely.
we'd like to request the faculties to take over, please. Dr. Ashish sir, Dr. Mijal, Dr. Debabrata Barman, Dr. Ranajit Mandal sir, and Dr. Kamna Datta. Please take over. And the students, you can introduce yourself and start presenting.
All are renowned oncologists. So I believe that you will be involved in the crossing process. Yes.
Ashish sir.
Yes, Dr. Padhi.
Yeah,
This
sure.
is Dr. Ashok Padhi. Yeah, there are students from
Thank you for your students' preparation.
Yeah. They will present before you. And,
Yeah, thank you so much.
Thank you.
Want expert
Students, you
opinion
can introduce yourself and start presenting. And the
Anvisha?
faculties to take over, please.
Dr. Anvisha. Dr. Barman sir, how are you?
Yeah, I'm fine, Ashok.
Okay, Dr. Annesha, could you start your presentation now? Annesha, are you there?
Please unmute yourself.
Yeah.
Anvisha, unmute and start presenting. You are muted. Unmute yourself.
Yes.
Yes, sir.
Yeah, please go ahead.
Sir, am I audible?
Yes,
Yeah,
you're audible
go
and
ahead,
visible. And
Yes,
the
sir.
slides are also okay. Okay, go ahead.
Okay, sir. Patient's particular, Mrs. X, Y of Mr. Z, IPD number 211 XXX 2156, age 54 years, religion Hindu, address Balasore, 180 kilometers away from HPGIC Cuttack, occupation homemaker, socioeconomic status lower middle by modified Cook-Pusamy scale, date of admission was 2nd February 2025 and date of examination is 2nd February 2025. Chief complaints: the patient presented to the gynecology OPD with complaining of postmenopausal bleeding for last 1 month. She also complained of foul smelling offensive vaginal discharge for the same duration. History of present illness: the patient was apparently well 1 month back. Since last 1 month, she complained of bleeding per vagina. She had 2 episodes of bleeding, which was irregular and was moderate in amount with passage of clots. It was also associated with foul smelling discharge. The bleeding was not associated with pain abdomen. Both the episodes persisted for 3 to 4 days, for which she had to take 4 to 5 sanitary napkins or sanitary pads per day. Bleeding was not relieved with medications as advised by some local doctors. She had no menstrual irregularity before attaining menopause. Important negative history. There was no history of any hormone replacement therapy, no history of any mass coming out through vagina. There was no history of any pain or abdominal distension, no history of any routine screening like pap smear or HPV testing. Menstrual history. She attained the menarche by 14 years of her age. She was menopausal since last 6 years. She has complete menopause since last 6 years. Her previous menstrual cycles before attaining menopause were regular and normal. The duration were 4 to 5 days. Flow was average 2 to 3 sanitary napkins per day, and the interval was 28 to 30 days. Her obstetric history. She was married at 20 years of her age. She is para 3, living 3. All were vaginal delivery. Her first childbirth was at 25 years of her age. Last childbirth was 23 years of age. All the deliveries were uneventful and bilateral tubal ligation was not done. This is the obstetric history. Her first child age is now 29 years. She attended twice. ANC attendance was 2 times only. Her period of gestation was 39 completed weeks. Type of delivery was first delivery was by vaginal delivery with episiotomy. She had no complications in the puerperium. The baby was alive and healthy, and it was breastfed and all vaccinated, and all 3 babies were vaccinated. Second baby age is 25 years. ANC attendance was 2. Period of gestation was 38 plus 5, and type of delivery was vaginal delivery. And the third baby is 23 years old with 3 regular ANC attendance at the period of gestation, 37 weeks, 2 days, with not only vaginal delivery, and the baby was healthy. Her past medical or surgical history. She was not a known case of diabetes mellitus, hypertension, thyroid disorder, asthma, tuberculosis, or any other chronic medical illness. She had no history of any immunosuppressive disease. She had never been treated for any sexually transmitted infection or STI. Contraceptive and drug history. She had never used neither condom nor oral contraceptive pills. Family history. She had no family history of hypertension, diabetes, tuberculosis, or asthma, and no history of any genital or extragenital malignancy in her family. Personal history. She had no addiction or allergy. She had adequate sleep. She didn't have multiple sexual partners. She didn't have any history of smoking or chewing tobacco. Functional history. Her bowel bladder habits were normal. There was no history of hematuria or bleeding per rectum. Sleep was adequate and appetite was normal. Nutritional history. She used to take 35 gram protein average per day, which is less than the recommended. Otherwise, she had no other signs of micronutrients and vitamin deficiency. Treatment history. She consulted at local healthcare facility for this bleeding per vagina, where she had been prescribed antibiotics and tranexamic acid for 7 days. In spite of that, the symptoms did not subside on this medical management. Now coming to the general examination, which will be presented by my co-MCH.
Good afternoon. I am Dr. Anirban Talukdar, the second year MCH resident of HPGIC Kotak, and now I will present the general examination of the patient. The patient was conscious and oriented with time, place, and person. She is a patient of average build and nutrition. The height is 154 centimeter, weight 48 kg, with a BMI 20.2 kg per meter square. On general examination, she is hemodynamically stable. Her pulse was 88 per minute at the time of examination. Blood pressure 122 by 70 millimeter of mercury. She is normothermic, and the respiratory rate is 18 per minute. There is mild pallor. There is no icteria, cyanosis, clubbing, lymphadenopathy, or edema. Neck veins not engrossed, and neck glands are not palpable. And the systemic examination revealed a normal higher mental function with no sensory or motor deficit, normal power in all limbs, and no abnormal movement. Her respiratory system examination revealed a central trachea. On percussion, bilateral resonant note is heard. On auscultation, there is bilateral vesicular breath sound without any added sounds. Our cardiovascular system examination revealed a normal precordium with a normal S1 and S2 with no added sound and murmur. Her breasts are bilateral symmetrical. The nipple areolar complex is normal with no abnormal discharge, and there is no lump or no axillary ligament palpable. her abdominal examination revealed the abdomen appears lax, their skin was healthy, the umbilicus central and everted, there's no scar mark, no engorged veins, and the hernial orifices are intact. On palpation, the abdomen is soft and non-tender. There is no suprapubic lump palpable. There is no ascites, no organomegaly, no renal tenderness or any tenderness over the abdomen, and there is no enlarged regional inguinal lymph node. Percussion is on percussion there is tympanic node, and on auscultation the normal intestinal peristaltic is heard. The local genital examination revealed on inspection the external genitalia comprised of the vulva, the urethral orifice are the healthy. The perspective examination there was an ulceroproliferative cauliflower-like growth of approximately 3 to 2 centimeter on anterior lip of cervix, which bleeds during the insertion of the speculum. There is no extension of the disease involving the vaginal mucosa. The VIV was done and it's positive, and there is no acidoid area seen on the vagina. The parvaginal examination also revealed a normal size uterus, anteverted and mobile. A firm mass of approximately 3 to 2 centimeter size felt in the cervix involving the anterior lip. The vaginal wall around the cervix was free, no mass or growth palpable. Her bilateral fornices are free, there is no induration. Her parrectal examination, digital parrectal examination revealed the same size of mass palpable at the cervix. Her bilateral parametry are free, rectal mucosa free without any thickening of the rectovaginal septum. So to summarize, the Mrs. X, a 54 years, para 3, living 3, from Balasore, admitted on 2nd February 2025, belonging to a lower middle socio-economic status, married at the age of 20 years, and first childbirth having at the age of 25 years, all vaginal delivery, came to the gynae OPD with a chief complaint of postmenopausal bleeding with false spelling of offensive discharge since last 1 month. She had regular menstruation before and attained menopause 6 years back. Her menopausal transition was normal. She first noticed sudden brisk bleeding per vagina 1 month back, and it was moderate in amount, which stained her undergarments. Subsequently, she noticed the bleeding once more after 10 days. She had no history of pain or any other urinary and rectal symptoms associated. She had never used any contraceptive and never underwent any screening for CSRVs or any other cancer. On general survey, she looks pale, ictus absent, no pedal edema. She is hemodynamically stable and her temperature is normal. There is no neck glands enlarged or engrossed, and the inguinal and axial lymph nodes are not enlarged. The cardiovascular, respiratory system are essentially, and central nervous system are essentially normal. Per abdomen examination normal. Inspection of the genital system, that is the vulva, vagina, are normal. Specular examination reveals a 3 to 2 centimeter size growth arising from the anterior lip of cervix with bloodstream discharge. The rest of the vagina, anterior and posterior wall, they are normal. On bimanual examination, the uterus normal size, cervix is firm with irregular growth in the anterior lip of the cervix. Uterus is mobile, fornix is clear, no vaginal involvement. Parectal examination revealed the free rectal mucosa with normal bilateral parametria, and there is no indurations. The rectovaginal septum is not involved. So our provisional diagnosis is a 54-year-old woman, P3L3, presented with carcinoma cervix, clinically stage 1B2. Sir, sorry for the typo error. This is P3L3, not P12.
Okay, so we can skip here at the provisional diagnosis, and it looks like a fairly straightforward case. It will be interesting to know what are the differential diagnoses that you have drawn up, and we'll go to that. But before that, we have a galaxy of very well-known, renowned gynec oncologists here. Dr. Bijal is here. Dr. Bijal Manish Patel, are you there, madam?
Yeah, I'm here.
Okay. Yes, nice to see you. Dr. Devabrata Burman is here. We have already introduced him. Dr. Ranojit Mondal, my dear friend, he is just my neighbor institute, that is CNCH, Chittaranjan National Cancer Institute. He is also there. And Dr. Kamna Datta is there, who is a professor of Atal Bihari Vajpayee Institute of Medical Sciences, Ram Manohar Lohia Hospital, New Delhi. So we have a case here. And before we proceed, would you like to see the differential diagnosis that they have drawn in this case?
Yes.
Okay, go ahead then. Last slide, perhaps. Yes.
The differential diagnosis are cervical polyp, cervical fibroid, or endometrial growth or carcinoma.
So, panelists, I mean the examiners, are you happy with the differential diagnosis, or do you add or subtract 1 or 2?
Sorry, we have to subtract 1 at least.
Which one, sir?
Which one? Which one, sir? Which you need to subtract?
Sir, carcinoma endometrium.
In spite of knowing the fact that the carcinoma endometrium cannot be matched with this particular case presentation, but
Yes,
you have
yes, sir.
presented the case very nicely. What I want to just put certain suggestions regarding the presentation of case. I have seen you have presented obstetric history in details. I think that is you are over presenting something. And second thing, you said every day protein intake is 35 gram. How do you assess the 35 gram of protein intake every day?
Just one, this thing, obstetric history, actually, what I mentioned to them in the dry run session is that you must write the obstetric history in detail in column form. But while saying the case, what is your case, then you can make an obstetric summary. So obstetric history summary is to be presented while presenting the case summary. And obstetric history, for the record's sake, they have kept a record. This is not to be told to the examiner while presenting the case. Okay, and about the protein...
39 plus 0 week, 38 plus 2 weeks. Is it possible for any lower middle class socioeconomic status lady to reveal this particular obstetric fact, which she has delivered 25 years back or 20 years back? Is it possible for somebody to remember? So these are all practical things which you have to keep in mind. Understand?
So what is the students' intake input about the diet history and the protein intake or deficiency of protein? Could you elaborate on this?
Sir, as we all know that carcinoma cervix is mainly as carcinoma cervix can occur in any population, but it's prevalent in the lower socioeconomic status or lower middle economic status and with protein deficit or any cachectic patient. As we can see that her BMI is also just borderline. It's only 20.2. That means, and weight is only 48 kilo. With 154 centimeter, and that means that she is in the malnourished category.
Which is the cutoff level?
Sir, pardon? 18.5 to 24.9.
Yeah.
No, but Annesha, I think you didn't catch hold of Dr. Ranajit Mondal's question. He asked you, how did you calculate how much of protein she's taking daily? Did you go into the detail of the dietary?
Sir, we asked her in details that what kind of food she take during her days. Usually, sir, many people at Odisha, they are usually from vegetarian only. They don't even have chicken and meat or anything else, and they don't take. Usually, maximum patients are they only take plant proteins, and these patients used to have eggs along with that, and from that only we calculated. This is an approx. This is not exact one.
What is the recommended protein intake per day?
So 1 gram per
1 gram per kg body weight per
1 gram per kg per day.
Yeah. So that way her body weight was how much? 52 kg.
No? 48, sir.
Okay. So she is deficient about
13
gram of protein intake per day. Okay. Does that satisfy Dr. Ranajit Mondal's question?
No.
Okay, then Dr. Anvesha, coming to your examination, you have told per abdomen is normal. If there is a central mass on your per abdominal examination, then what are your differential diagnosis? What will be your differential diagnosis?
Ma'am, if there is any central mass, first the differential diagnosis will be, it might be a case of full bladder.
True.
And then fibroid uterus. It might be any ovarian malignancy. And even we have seen presenting CS cervix endocervical carcinoma or presenting with pyometra or hematometra.
Very good, very good. So we have to keep in mind full bladder and pyometra, hematometra when patient presents to you with the central mass.
Yes, ma'am.
Okay, Dr. Anuvesha, now you tell me, based on your history, so when you're saying your differential diagnosis and diagnosis, tell me points favoring your diagnosis in history and then examination.
Okay, ma'am. Ma'am, from history point, as the patient presented with, one of is that the patient presented with postmenopausal bleeding. Number one. Along with that, it was associated with offensive foul-smelling vaginal discharge. We can imagine from this scenario that there must be some physical lesion which got infected, and that only presented as whitish foul-smelling discharge. This one is the thing, and we know that the cancer cervix is the third most common cause in the as the malignancy in lower middle income countries and developing countries like India. And after that, ma'am, as she is from the lower socioeconomic status and she belongs to that 180 kilometers away from Cuttack. This is from Balasore, and her BMI is also on the borderline. And there was no, she had never used any, she is multiparas lady and got married at 20 years of her age, and she had her first light birth at 25 years of her age, and she had 3 babies, and she never used any condom or any contraceptive pills and all these things, and she never had any screening throughout her lifetime. From this and from my examination findings, that there was already 3 into 2 centimeter size mass seen on the antral lip of cervix. All these findings suggest that it might be a case of carcinoma cervix.
Correct. So you have to tell about the risk factors for CA cervix and rule out the risk factors for carcinoma endometrium, right? So
Yes,
that
ma'am.
is done.
Yes.
Okay.
So you have mentioned about in the personal history that she didn't have any addiction, right, like smoking. Does smoking have a beneficial effect or derogatory effect on the carcinoma cervix?
Smoking has, sir, obviously smoking has a negative effect on carcinoma cervix.
Is it?
Yes, sir, because the carcinoma cervix pathology is dependent on
HPV.
HPV vaccine, and also smoking. They reduce the antigen presenting cells, and thus because of the immunogenicity of the HPV associated. So by decreasing the immunogenicity, smoking increase the chance of CA cervix.
Okay. So anything else in the history that you have mentioned almost everything. So you should start always with the socioeconomic status, the age of the patient, multiparity, early marriage, and early sexual exposure, and then go into the examination finding. That's fine. I would like to take the opinion of the learned examiners as to anything else that you want to add in the history or examination, or you want to infer, or you would like to go for the investigations and management.
You can add the history of vaccination if the patient is young. Nowadays, you have to add that history. She has been not vaccinated or vaccinated.
Yes. Madam, as she is 54 years, as she is
that I
54 years of
understand.
age,
But
and
if the
she is beyond
patient
the
is
time of
young, then
vaccination. So
We have omitted that.
So we have omitted because at that time
I
actually
agree. But if you are presenting a young case history, then you have to.
yes.
And it will
So
be young case
postcoital bleeding also, I don't know
There
if
was
I
no
missed it.
postcoital bleeding, madam. There was no
You
postcoital bleeding.
mentioned, I
Actually,
believe.
ma'am, she
That's
didn't.
very important
didn't
history
complain.
for.
Honestly, you said CA cervix is the third most common cancer in India. So is it true?
In females, sir. I mean, not, sir,
In
first
females.
is CA breast, and then colorectal carcinoma, and then CA cervix.
But I as far as I know, it is the cervix the second most common.
Second, yeah.
It is second.
Second.
As
It is
per
the second most
global
common.
In
control, it
India,
is second most.
Second most.
Yeah.
And globally?
Fourth
Global-
most.
Fourth most.
Yeah, fourth most.
Globally fourth.
Fourth most.
Endometrium comes before.
So
Correct.
your Anisha and Anirvan, so your case is she is 54 years, isn't it?
Yes.
Yes, sir.
So in CA cervix presents a two bimodal pattern of age. Do you know what are those?
Yes, sir. One is, sir, within 45 to 55 years, and another peak is 65 to 75 years.
Is it? I think it is 35
to 45. It is
Yeah.
35 to 41.
35 to 40. Yeah. Next is here. And what is the difference in the bleeding pattern between CA cervix and CA endometrium?
Okay. Sir, in case of CA cervix, the bleeding might be intermittent. It can be brisk bleeding, and there might not be heavy bleeding or any passage of clots every time. It's not seen. But in case of CA endometrium and in case of CA cervix, the bleeding is irregular. it might be intermenstrual bleeding also. But in case of CA endometrium, the bleeding is heavy, usually in regular pattern, and it's usually associated with passage of clots and pain.
Altered color. And what is the difference of bleeding pattern between an early CA cervix and a late CA cervix? Advanced CA cervix?
Okay, sir, in case of early CA cervix, the bleeding is usually mild and it's fresh blood. And in cases of the late CA cervix, the bleeding is excessive bleeding. Even we have got patient with hemoglobin report 4 and 5 only, and heavy bleeding and passage of clots, and that associated with
Rectal and bladder symptoms
and
in
with
later.
hematuria and bleeding per rectum. They
Another
present.
important thing in the early is that they will complain of post-coital bleeding.
Yes, yes, sir.
That is generally we see in early sometimes. Okay.
Early, sir. Yes, sir.
Yeah. Regarding the relative risk of sexual partners, you told there is no history of any multiple sexual partner. Why you have asked that? What is the relation?
Sir, in case of if there is multiple sexual partner, there is increased risk of having malignancy.
Do you have any
as well.
idea how many multiples, how many partners, and what is the relative risk?
Sir, no
There
idea,
are
sir.
data
Relative
which
risk,
have shown
no
that-
idea.
Okay,
But
there are data which
for
have shown
multiple
that
partner,
2 partners, relative risk is 2, and more than 6 partners, then relative risk 3 tries. So that is what is there in the literature.
Okay, sir.
Okay, now I think we can go to the examination.
Yes, if you go for screening in a sexually active, I mean, in a promiscuous region, you'll find almost 50% of them are HPV positive. Else, in a normal population, you'll find 5 to 10% is HPV positive. So that is what we have observed in our, a regular program. So that's very true. When you have multiple sexual partners or the patient is going for a promiscuous, there is always an increased chance, there is no doubt, as Debabrata says. Yes, very true.
Okay. So if we have finished the history and examination,
yes,
and the provisional diagnosis, and you were happy with the differential.
Not yet finished.
Not yet. She has to
Not
say
yet
the
finished.
examination findings.
Not yet finished.
How she will proceed.
You please tell us the provisional diagnosis.
Go to the provisional diagnosis.
Yes, sir.
What is the provision? Last slide. Anirban.
What's your provisional diagnosis? Without saying
the provisional diagnosis, a 54-year-old P3L3 lady from what middle socioeconomic status with a clinically stage 1B2 CA cervix.
Okay.
1B2 CA cervix. This is the diagnosis, clinical diagnosis offered by you.
Yes, sir.
Yes, sir.
Yes, and you have 2 provisional diagnoses. I mean, a differential diagnosis.
Sir, we have written as 3: cervical polyp, cervical fibroid, and endometrial carcinoma.
So in any way, it's a cervical polyp. Do you think it's polyp?
Sir, it might be.
It might be.
You are
Until and
mentioning
unless-
ulcerative growth, then how can you give a
Ulcerative.
differential diagnosis of cervical polyp?
It's a less chance of cervical polyp because it is on the anterior lip. An infected and degenerated fibroid may be a closer one, but polyp and is not.
Anyway, polyp will not be there, isn't it? And
so a well circumscribed growth in the anterior lip of the cervix reasonably rules out cervical polyp in this case, right?
True.
That's what we want to say. Okay.
Any other differential can you give in, especially in this part of the country?
Ma'am, cervical TB.
yes.
Yes. Cervical tuberculosis and actinomycosis. These are 2 other differentials, though rare. Yeah.
Can come.
So you have kind of ruled out, say, endometrium. I believe we are not putting this in the differential now in further discussion. Yes, or do you still have a differential? Can you still justify?
Ma'am, we have seen endometrial growth coming through external os, and it presents like just polypoid mass. And when we have taken some biopsy and it came to be as adenocarcinoma first, and then we have gone for ER/PR, Vimentin and P16, and then finally the diagnosis. If it is the endometrial carcinoma located in the lower uterine segment, that can present as this cervical growth.
I agree.
I mean,
rare
endocervical
possibility.
growth.
This is a rare
Rare
possibility.
It's a possibility that is protruding out of the os.
Yes.
Can
yes.
it be also endometrial carcinoma metastasizing into the cervix?
Very unlikely.
Yes,
Yes,
may,
sir.
it may happen.
Yes, sir. It may happen.
Okay.
Or synchronous cancers, yes?
Or synchronous.
Yes, synchronous cancer.
So
Okay.
how often you encounter this synchronous cervix and endometrium?
So how do you rule that out? I mean,
How
what
do
are
you-
the procedures from this point onwards you take up for a correct diagnosis or a final diagnosis in this patient? Tell us.
Okay. Sir, first we'll go for imaging. First we will take biopsy from the mass as it is seen, that is cervical mass or endometrial mass, whatever it is, we will send biopsy. The biopsy will be taken from the normal and the tumorous zone, so that thus we don't take any necrotic tissue in our biopsy specimen. And when the biopsy report comes, if it might be come as a squamous cell carcinoma cervix, or it may come as adenocarcinoma, or else it may come as endometrioid or polydifferentiated carcinoma, which we encounter. And after that, to differentiate it, first we will go for MRI scan, and on MRI scan, there
MRI
we
of
can
what?
locate MRI of the
MRI of the
pelvis,
pelvis.
CMRI,
Mention it.
contrast enhanced MRI scan of the pelvis, and the MRI scan can give us precise location of the growth if it's actually the lower uterine segment or the endocervical canal, and it is coming out through the external os or not, and if the endometrium is involved or not, endomyometrial junction is maintained or not, cervical stromal rim is involved or not, and vagina and or parametrial status, and most importantly lymph node status. Everything we can know, and one precise location can be done. If the report comes to be as adenocarcinoma, then we'll send for immunohistochemistry, and that is the ER/PR, Vimentin, and P16. If P16 is positive, then it's endocervical carcinoma, and if ER/PR and Vimentin are positive, then it's endometrial carcinoma. Thus, we can differentiate finally.
Can P16 be positive in endometrial cancer? Is it always the P16?
Yes, sir.
Yes, sir.
P16
can be
P16
positive.
positive in serous
In
cell
which
cancer, endometrial
condition?
cancer.
In
Which
which
variety?
condition?
Which variety of endometrial cancer?
Clear
Serous,
cell and
serous,
serous.
serous.
Yes, it's serous variety. So from imaging, can you tell about the epicenter of the lesion from MRI? Whether it is endocervical
Yes, sir.
or
From MRI, yes, sir. It can be diagnosed from the MRI. If the lesion comes from the endometrial cavity above downwards, then we can tell that it might be a case of endometrial carcinoma. But if the lesion is localized in the anterior or the posterior lip of the cervix only, and the lesion is smaller in size and confined to the cervix only, then we can see that it might be a case of endocervical carcinoma. But the origin in case of the endometrial carcinoma will be above. That we can see in the console, that the mass is coming from above downwards. By this, we can differentiate.
And I
And on
assume that.
and on histology, what features will you see in both the biopsies?
Ma'am, in case of, if we suspect for squamous cell carcinoma,
If there is adenocarcinoma, you may can find associated intraepithelial lesions, squamous. In an endometrial malignancy, you can see hyperplasia, atypical hyperplasia. That are the features you can see on histology.
The associated pre-invasive lesions are there. In endometrial, EIN kind of things you can observe along with that. But
yes, sir.
In some slightly mentioned by Patel ma'am.
Dr. Anvesa, do you not practice taking endometrial biopsy in patients with the cervical growth?
Yes, madam.
Yes, ma'am.
Do you? So
Yes, madam.
you need to mention that also when you are telling us the investigation for this.
Yes, madam.
patient,
The
right?
cervical biopsy, biopsy from endocervical canal and biopsy from endometrium,
Correct.
all three
will be sent.
will be sent
So
separately.
please mention all three of them, okay? It's
Yes,
not
madam.
just the... Yes.
Okay. So you would like to let me ask you another question. Is MRI mandatory in all cases? You routinely do MRI in all cases of carcinoma cervix, or you select your cases?
Sir, in that case where there is this clinical stage 1B2, so that we can plan surgery. So MRI can give us the anatomical extent of the disease, and if the anatomical extent is of the MRI is at par with our clinical diagnosis, and if there is no lymphadenopathy, lymphadenopathy can be shown with CT scan abdomen, but if the parameter is not involved, if the vagina is not involved, if the growth size is less than 4 centimeter, so that can be precisely told by MRI, and so in that case we can plan for the surgery. Otherwise, we will send the patient for CCRT.
So clinically, from the vaginal examination, from the parectal digital examination, you have found out that there is no signs of any parametrial involvement. However, the clinical assessment may not be accurate always. So I agree with your decision of MRI for these cases. But there are many places where the MRI cannot be afforded. So what do you do there? I mean, you straight away go take up for surgery, or you go for the more correct staging of this case before going for surgery. What do you do? Or it's
Sir, you will see ultrasound, both trans-abdominal ultrasound and trans-vaginal ultrasound in experienced hand. That can also be done.
That can also give us the anatomical extent. Transvaginal ultrasound, one disadvantage is that it cannot give us about the lymph nodes, pelvic lymph node status.
Pelvic lymph node status we can.
But anatomically, in an experienced transvaginal ultrasound can also give the anatomical extent and the parametric involvement of the disease.
Even you can do examination under anesthesia associated to confirm your findings.
So what do our panelists, learned panelists say? Should MRI be mandatory in all cases of carcinoma cervix in order to accurate assessment of the parametrium, or you rather go for surgery without MRI with the help of the ultrasound maybe? Ultrasound is basic in almost all the centers, but MRI may not be so. So what is your opinion?
As Anirban said, he's justified. His answers are justified as far the MRI is concerned. If you are really wishing to plan for surgery, so it is better to do the MRI before undergoing the surgery, because of the fact you may land up offering dual management for this patient: surgery followed by chemoradiotherapy. So that is just over treatment which you are going to do. So in that way, when you in fact we hardly get patients for surgery, because of the fact previously we used to do for many cases, because we used to do the assessment clinically. So there are a lot of cases which you feel that probably this is the parameter is not infiltrated, but actually when you have done the MRI or CT scan or ultrasound, what you are saying, then you will say that many of the cases are having parameter infiltration where the surgery is contraindicated.
Correct.
And this is very true for when there is an infiltrative disease. When exophytic disease is there, then you can rely upon your clinical and ultrasonography. But since the staging, lymph node positivity is there, and you have to exclude surgery, for that reason you need MRI.
Because
to see the lymph
FOGSI
node
2018 has already mentioned that this pathology and imaging should be a part of staging system. So if you get any notes preoperatively, you can abandon the surgery. And you can go for the evaluating mode, the status of lymph node. And if it comes to positive, then you can abandon the patient. So many unnecessary surgery can be avoided by doing a imaging. And also FIGO 2018 has already advocated to go for imaging as it is a part of this staging system.
So
apart from decision for the surgery,
and when it is a matter of surgery, it will be referred to the higher center for the surgery, where all this facility will be available.
Yes, that means that the in our student days, I remember those days, Amrajit, also my age, I think we used to see many cases clinically at stage 1B2 diagnosis. We always used to jump for surgery and then find a surprise parametrial involvement and remove yourself from the surgical spot. So gone are those days, and naturally, with the advent of the diagnostic imaging and surgical techniques, I think the mortality and morbidity should improve.
Yeah, and node positivity is a contraindication for surgery, because you have to avoid the both dual modality of treatment. So if you're getting a notes, then that is suspicious. It will be you need to evaluate more and to exclude nodal involvement.
The
You
node
can abandon
positivity from which extent?
Is-
Because in
Is
one
a
stage
con-
one
it is contained any kind of lymph node positivity will definitely add for adjuvant chemoradiation. So if you are getting better to avoid a node positive, to know the node positivity prior hand before surgery. So if you are aware that the node is enlarged and it is involved, better not to go for surgery. Because now the dictum is after opening the abdomen also, we go to send the node for frozen section first. And if it comes to positive, we abandon the patient. Because we will not allow the patient to get both modality of treatment. Because patient has to suffer the morbidities of both surgery and also the radiotherapy. To avoid that, you should be very precise your diagnosis, so that it is once node is positive, it becomes stage 3C, 1C2 as per FIGO 2018. So we have to
Dr.
avoid that.
Padhi, just allow me one question. If you do investigate or not, if you find signs or clinically or investigatively, the stage 1 also disease also has got 15 to 16% node involvement.
Yeah.
Isn't it?
Yes, very less in
sir.
stage 1A. Yeah.
Yeah. Then
1A1 is very less, but 1B1
after 1A2 onwards, there is fair chance of pelvic lymph node and parotid lymph node involvement. 15 to 18% chance of this there.
And in one study, sir, it was seen that when the WHO 2009 and 2018, the staging were analyzed, that why 2018 has come in the study, it was seen that maximum upgradation was in the stage 1B. It was almost 63% by imaging. When imaging got added, only 1B.
So the thing is that it may so happen that by
3C1.
clinical examination, it thinks it's operable. When the node is there, then it becomes inoperable.
So that means it restricts the surgeon's hands.
Yeah.
Surgery in any case.
Yeah. In node positivity, you should not go for surgery. Why the patient will get tolerate both the morbidities of both the modality of treatment, both surgery and chemoradiation. So better this patient should be referred to chemoradiation straight away.
So there is limited scope for the surgeons.
Yeah. If node positive is
even in stage 1 disease.
Yes. If one
Even
be
in stage 1 disease,
all the panelists agree with this.
Yes, we have very much. We are in fact not getting many cases for surgery as per the CSI is concerned. So it is previously used to get at least 4 or 5 cases in a week, but nowadays hardly a case in a month. It's very difficult to assess and assimilate all those things.
Yeah. So after this thorough evaluation.
Yeah. So as it is, the disease is relatively asymptomatic and it progresses silently. So that was our initial observation, that most of the patients presented with the stage 3. Today, in the presence of vaccination and screening, I think it may be slightly different. But even then, the surgeons, I don't find much role in the treatment of the carcinoma cervix, even in early stages.
Very simple question, Dr. Anvesha. How do you assess parametrial involvement for all the audience and residents who are listening to you?
Yes, ma'am. Ma'am, for parametrial assessment, I will go by per rectal examination. First, I will insinuate my index finger, one finger through the rectum. And
only the per rectal examination?
Ma'am, per vaginal examination, per rectal examination, and rectovaginal examination. Ma'am, by per vaginal examination, both the fornices I will assess both the fornices by manual examination. And after that, I will go per rectal examination. I will put my index finger through the rectal mucosa, rectal canal, and I will assess the rectal mucosa. Then first I will go upward and then right on the right side and on the left side. And even higher parametrial examination we can do if we suspect for any parametrial involvement. And on per rectovaginal examination, we will assess the rectovaginal septum.
So I differ here. Per rectal, it's the vagino-rectal PVR examination, which will actually help you assess.
Like that.
Right?
It's
not the per rectal.
At the same time, you do the vaginal, one finger in vagina, one finger in rectum.
One finger in the vagina, one finger in the rectum.
Yeah.
Only PR examination will not help you assess the parametrium. Okay, for all residents, it's very important. You say this in the Viva.
Dr. Anvesha, sorry, you continue, sir.
Okay, so you told in the vaginal examination, you look for the fornix, okay? And so anything which you see only in the vaginal examination, which you have to assess during the vaginal examination only, that cannot be done with the PV examination.
Rectal, you mean?
Rectal examination.
Vaginal.
Oh.
Sir, adnexal status.
None. That is the rectal also you can see.
Rectal also we can go.
Anterior vaginal wall.
Yes.
That is the thing, important thing, which you have to assess during the vaginal. Apart from those, that you have to mention. Okay. Yeah.
Okay.
And Dr. Anvesha, you had applied acetic acid during your examination. What was the rationale for it?
Ma'am, in our institute, we usually don't do VIA for advanced stages. If it's clinically advanced stage, then we don't do. But if there is any suspicious cervical growth or any small growth, in this case, we have done the VIA to assess the vagina. If there is any vaginal lesion or acetohyte area extending onto the upper 1/3 part of the vagina, or how much it has extended, then if we plan for operation, we will plan accordingly. How much vaginal margin we will take.
We will keep in the mind the vaginal extension so that it has been written and it will be planned
If
accordingly.
the upper
during the
third of your
vaginal
posterior
Yes.
vagina is unstained,
Yeah.
then what will you do with it?
Sir, ma'am, if posterior
If your
vagina is
posterior
VIA
upper 2/3 vagina is VIA positive, then how will you go ahead? And it is early cervix, early small growth.
Okay. Ma'am, if posterior 2/3 of vagina is involved, then it's stage 2A. Now,
It's 2A.
clinically, it's stage 2A. If the growth size is less than 4 centimeter, that is stage 2A1, then only we can plan for radical hysterectomy.
If it
I
is
will
2A2,
advise you to
And
take the biopsy from unstained
biopsy.
area. And if there is dysplasia, then and then you can abandon surgery. Sometimes there may be infection and then there is a unstained area. So you have to confirm the findings.
So the message is that in the before surgery also, and the OT also you should do it with VIA to know the margin at least.
Yes, sir. Yes.
And you can demarcate the margin for the surgery. Along with that, what my madam has told, that means if you can take a biopsy, but it's suspicious. But many times due to infection also, that may be some positivity. So you should be pretty sure that what kind of surgery we are going to do. And your extent of surgery, taking the vagina, how much vagina you will take. You should demarcate prior hand so that you can, accordingly, you will take the vaginal margin. So that will also add in the surgery.
Also, in terms of vaginal involvement, is VIA that specific and sensitive? My question.
You have to confirm with the biopsy. You
To
have to
confirm, it is to confirm the biopsy under
Biopsy, so biopsy from the vaginal VIA, if it is VIA positive, biopsy will be taken and it will be the gold standard. But we can corroborate with the findings.
Yeah, or else it can, if you have a suspicion that it can be very well demarcate with the lugolcidine. So if you have,
sir, we
Yes,
use
sir.
sir,
We
we use
use-
actually we the everything is done under colposcope with VIA and
VIA,
VLA.
VIA and VLA.
so also, do you do the colposcopy just before the surgery in the OT?
In this
No,
side,
sir, we have no facility in
Not
OPD only.
usually. In OPD we are doing, not doing. But thing is that
In
only to
OPD.
take the margin, actually, particularly in case of 2A, and many times there is extension because we think that some kind in post-speculum examination, you think the vaginal wall is involved, but we have to be more sure. For that, we can go for a VIA in OT to particularly take the margin, vaginal margin. So that the whole idea is to get a margin free. Whole idea in oncology is that to get a margin free.
So it's
And at least one centimeter margin should be.
If you do the painting, when you have this type of cases, if you have a painting with lugolcidine, so that will give a clinically at least. It's very difficult while doing the surgery. It's very difficult the extent of the lesion. So it is very evident when you apply the lugolcidine. Yeah, you won't be able to remember at which level you have done the thing. But if you apply the lugos immediately before you ask the resident to put lugolcidine, that will give you a clear-cut margin, and your thing will be very clean-cut.
Yeah, no doubt.
So immediately after VIA, you can put lugolcidine, right?
Yeah.
Yes, sir. Yes, sir.
Yes, sir.
But it will not persist, sir, for more time. It will maximum persist for
5
30
minutes.
to 20 minutes. Nothing
No,
more
you,
than that.
yeah. We
For,
usually take a marking
leukocytin,
pen.
even
You
for
usually take a
leukocytin,
marking pen.
even for leukocytin, it will not persist more than
Persist for
20
long.
minutes.
Okay.
So,
The problem, immediate problem may be that कुछ दिखाई नहीं देता हमको after putting leukocytin.
नहीं सर क्या होता है कि
Yes, under colposcope.
Under colposcope, sir, we can.
Yeah.
But
that
actually
is-
very small diseases like that, like stage 1A, 1B, 1B lesions. Actually, what happens when there's in some cases, we have found that this vaginal margin is involved. Vaginal, anterovaginal, posterior-vaginal is involved. To actually to get a proper margin, what you do, what the Mondal sir has told. Along with the VIA, if you do a VILI, and with a marker pen, we have a marker pen. Many times you go for abdominoperineal resection. We get a marking in the this vaginal margin, and then we will come from above, so that we can reach the particular margin. Because our whole aim is to get a 1 centimeter free margin.
So marker pen is very important. Annesha, how do you prepare your VIE? I mean, which strength of acetic acid do you use? 3%?
Sir, 3 to 5%.
Freshly
3 to
prepared,
5%.
You
Freshly prepared for 1
prepared
minute.
it freshly or you store it? You have a stored this thing collection of acetic acid in your OT?
Sir, before OPD. I mean, sir, before OPD, every day it's prepared, and for that day it's used.
Okay. So how do you prepare it in the OPD?
Sir, 5% acetic acid with no, so 95% acetic acid with 15 ml NS. 5 ml
no.
acetic acid with 15 ml NS.
No, no.
No.
You have never prepared because our attendant is preparing.
That's what
The
I
problem is
wanted
that
to know.
you never ask your attendant.
They use the prepared solution. They don't prepare it freshly. Isn't it?
Sir, I have made once, but I have forgotten.
Okay. So panelists tell us how to actually correctly prepare this acetic acid, 5%.
95 milliliter of distilled water and 5 milliliter of
Acetic
Glacial
acid.
acetic acid.
Distilled water and
glacial acetic acid.
95%. Okay.
For 5%.
95
ml plus 5 ml.
distilled water
95
5
ml plus
glacial.
5 ml.
So original acetic acid, you take 95%, right? Let's say
No, sir.
No.
5 ml.
No. Water, distilled water, 95 milliliter.
Ml.
3 to 3
And acetic acid, 5 ml.
5 milliliter glacial acetic acid.
Glacial acetic acid. Glacial acetic acid IBDP is 0.5%, no?
It's 100%, sir.
100%.
Sir.
Okay.
Unless it is very hygroscopic, if there is no, I mean, during the time of monsoon season, it may be 97%, but otherwise it's 100%.
Okay. Okay, so students, now you learn how to make the acetic acid solution. So henceforth, we will expect Annesha to better prepare the acetic acid solution. Okay. Now, once we are done away with this thing, now we will slowly proceed towards management because the clock is ticking.
Yes.
So in that case, I would like to ask the students to, stop your share screen so that we can see each other very well, interact very well, see the lovely faces of each panelist. That will be better for us. Are you finished with the slideshow or you have something more to show?
No, sir.
After differential diagnosis, you don't have anything to show. Right. Thank you so much. So come out of the share screen and you will see each other very well.
So, Anusha, your parameter is preclinically. So, how
Yes,
you
sir, parameter is-
assess the parameter on imaging? What you want to see in imaging, so that you can decide
Sir,
parameter.
okay.
Sir,
Yes, sir. Sir, we'll go for MRI and CMRI, contrast enhanced MRI, as it is available in our institute. And if we are planning for OT, then we'll go. And from the MRI, we can see that there will be one stromal rim. That is, if the stromal rim is intact, then that stromal rim involvement can be of 5 types according to the MRI findings. one is intact stromal ring, another one is inhomogeneous stromal ring. That means there is some infiltration might be occur, that is some in plus minus. After that, speculation, that means speculation of the focal breach of the stromal ring may be present. And after that, loss of the fat plane with the surrounding structures with and then final involvement of the stromal ring or parametrium.
The complete
Mainly
breach. That is complete breach. Last 5.
Yes, sir.
5 is complete breach of this stromal.
Sir, can't hear you.
5 is complete breach. 5 is
5 is complete
5 is the
breach.
tumor cell in the parametrium.
Yeah, yeah. So how many parameters are there? Have you heard about any types of parameters? Anything? Any idea? That's
Parametrium, yes, sir.
from surgical point of view.
Yes, sir. From surgical point of view, sir, there is one dorsal parametrium, another one is ventral parametrium, and there is the lateral parametrium.
So how would you proceed this particular case? You have done all the investigations and you have planned for surgery. How are you
Yes.
going? Yeah. How will you proceed?
What is your final diagnosis and staging in this particular case before you proceed for treatment?
Sir, this case was finally stage 2B, stage 1B, 2 only. There was no parametrial involvement was there, vaginal involvement was not there, and there was not any enlarged lymph node seen. And from all these findings, finally we stamped this case as stage 1B2, and we planned for radical hysterectomy.
Type C1
Type
radical
C1 radical
Type
hysterectomy.
C1 nerve-sparing radical
Nerve-sparing
hysterectomy.
radical hysterectomy.
Why are you telling 1B2?
So because
Sir,
the growth size is 3 centimeter,
2.5
maximum
into
diameter
3
3 centimeter.
centimeters, sir.
So,
And the
so my-
maximum diameter was 3 centimeter. That's
So
why.
B2 is up to 4 centimeter.
Up
Yes,
to 4
sir,
centimeter.
4
4 centimeter.
centimeters.
Suppose you get a growth of 2.9, 3.9 centimeter, and one is 4.1 centimeter. So the
We
stage
will
become
abandon, sir.
1B2
It will be
to
stage
1B3.
1B3. 1B3.
So how to differentiate? Are you
Sir,
so
the
particular
maximum-
in clinical examination? The difference between 3.9 and 4.1.
Sir,
So in
that will
3.
be
As per your sayings, 3.9 you will go for surgery. If it is the growth size is 4.1, you will abandon surgery.
Sir,
You will
actually,
go for chemo radiation.
in case of 1B3, when the tumor size is more than 4 centimeter, there are more chances of positive margin after surgery that
and there might be
needs
chances of
No.
dual
So
treatment.
my
dual
point here
modality,
is that my point you
but
should
see,
be very you should
3.9,
evaluate
4.1, sir, is difficult to answer because
Exactly,
that is
exactly.
according to staging. 4.1 and 3.9 is practically there is very less
1
difference.
millimeter gap.
But according to
why you are
staging,
not going for surgery in 1B3? My question is why you are
because
not
the
going for
chance of
surgery?
positive margin after surgery is there,
Margin
so
and-
the patient needs
And all
dual
other
modality.
risk factors,
Is
all
it
the
because
other
of
risk
only
factors for
positive margin or something else?
or
Node.
all the other
Sir,
risk
node-
factors like nodal involvement.
Nodal
In
There
1B3
is there is positive margin, positive parameter, and positive node.
Yes.
All the chances
All
can
the
be
chances.
high.
And we want to avoid dual modality. That
So
is
dual
mainly
modality. So if you are getting a 3.9 growth also, this may be 4.1. It is a subjective thing.
Yeah.
For you
Yes.
it is 3.9. For somebody it is 4.1. So you
Yes.
should twice and thrice evaluate. You should go for imaging. You should totally strict based on your imaging. You will corroborate your imaging findings also. Then you have to practice before going to surgery. Before surgery, it should be stamped as it is operable. Then only go for surgery.
Ashok
That's my
Padeji,
point.
sir, I wanted
Yes,
to know from you, how would you correctly measure 3.9 and 4.1? That's my question.
Yes, really not practical possible. That is my question. That's why I'm asking. It's not practically possible. It may be 3.9 for
Yes,
somebody. It is
that is
4.1
possible.
somebody.
You have to rely on MRI.
So you have to rely on MRI.
These
That's why I'm telling.
findings are very precise finding, Dr. Mukherjee. These findings are very precise. You can draw it in the console, and these findings are very
Yes.
precise.
Yes,
Oh,
that's why.
you
But
mean
you have to
MRI?
take.
I was talking about clinically.
No,
you have to take.
clinically it will
Clinically, there is
differ.
no
With the
way.
help of
There is no
MRI.
way, sir.
MRI.
There is no way.
Okay, so it makes all the more reasons for making MRI an absolute necessity for going for any treatment in customer service, irrespective of any stage. Treatment cost is increasing. My concern. Yes. So you have selected her for the surgery. What kind of surgery? What preoperative investigations, preparations, etc., etc. Tell us. Any preparation of the patient?
Okay, sir. Usually in our institute, if we plan for any radical hysterectomy, we will first build up the patient As she's BMI is 20.2 kilo, then we'll admit her, and after admission, vitamin C, multivitamin supplementation, proper food intake, is she is taking or not, and we will follow the ERAS protocol. We usually follow the ERAS protocol, and if the albumin status is low, if it's less than 3.5, then we usually give albumin infusion. And if the hemoglobin is, and we will all go for the routine investigations like CBC, LFT, RFT, thyroid status, and urine REME as CSRPs, and there is
just a moment. For this patient, what is the albumin level? For this particular patient, what is the level of albumin?
Sir, for this patient, it was 3.5 borderline.
Do you add albumin? Do you infuse albumin? In fact, it is
No, sir. For this patient, sir, we don't know, but
see, in very rare cases, preoperative albumin is infused. Don't give this idea. Even in ERAS protocol, they have not said that albumin is to be given in infusion form in a preoperative patient. Don't do. It is only given either perioperative period during the time of surgery or postoperative period. Preoperative period for building up the patient, don't give albumin infusion.
And also the BMI, we are not building her BMI by admitting, right? It's in BMI is a chronic thing. You cannot say
yes.
that you are going to build up. You see her hemoglobin, you see her, yeah. So
yes,
you
ma'am.
admit
But ma'am, we have
her.
seen many patients, ma'am, after during admission, they're just like sick and weak and very fragile type, and when got admitted and she has been given a multivitamin supplementation, if the anemia is there, if the hemoglobin is less than 10, we'll definitely give for PRBC transfusion. Even after 7-8 days, then they become okay. I mean, their ECOG status improves, ma'am. After then only we'll put her for OT. And all routine investigations, CMRI, and after doing all these things, we will plan her for OT, and we'll
It's
follow
very
the ERAS
important
protocol.
for you to assess her basic parameters, like you mentioned, her hemoglobin, TLC count, platelet count, coagulation study, liver function test, kidney function test, a chest X-ray, because she is undergoing a radical surgery, and you have to have a good baseline parameters
ECG
for her,
and
right?
echocardiography.
So whenever you are answering such questions, please mention all these investigations correctly in the full form types, right? We don't say CBC, LFT, KFT. You better, it's good for the residents to practice saying full forms of all these investigations.
Okay, ma'am.
Yes, ma'am. Yes, ma'am.
Okay, so you have built up your patient now, or anything left for building up the patient?
To build up. Now, what are you going to do?
I like this term. I will build up my patient. Sounds very, very professional type, in a corporate type.
So, Anvesha, which route will prefer for surgery?
Sir, as this patient was being planned for type C1 radical hysterectomy, we had planned by open method.
Abdominal.
Why not MIS?
Because the recent report of the lateral that has been published, and it has been shown that through MIS, that disease-free survival and overall survival is reduced than that of the open abdominal surgery.
Lateral, yes.
And there is increased chance of recurrence. There is 4% chance of recurrence in the cases treated by MIS.
So the patient, suppose the patient has come to you and he demands a minimal invasive surgery, laparoscopic radical hysterectomy. So how to counsel the patient? That is very important.
So we will counsel the patient according to the line of the reference and studies we have that according to the lateral, that it has been shown that there is a significant risk with a hazard ratio of 3.74 of decreased 3-year disease-free survival and overall survival than comparing the case to the open procedure. So better to have the open
lateral clearly, Dr. Anirban, lateral clearly mentions that you have to counsel the patient. There is a 4-time chance of developing the recurrence.
So
and there is 6-time chance of being the death. You have to tell him that term in patient's language also.
The hazard ratio is 3.74. That is 3.74, almost 4 times chance. That is I'm telling.
Yeah, 4 times. That you have to explain to the patient.
So if you are
Yes.
you are preferring a minimal invasive, there is a 4 times chance of death and 6 times chance
That
of
is I'm telling,
developing
sir,
recurrent failure.
hazard ratio is 3.74.
Why not vaginal route?
Why not vaginal? Very
Sir,
good question.
actually, we are not so
We are
much
not trained in that.
We are not
You are
trained.
from West Bengal.
about the radical vaginal hysterectomy or the SOTA procedure or whatever.
Who is the pioneer of in this field from West Bengal?
Professor Subrut Mitra.
Yeah, the person sitting on the extreme right.
Yeah.
Ranjit Mondal.
He is the first director of CNCI, probably.
Yes, he was the founder director.
He's a descendant of Dr. Subodh Kumar Mitra.
Who?
Dr. Ranjit Mondal.
So what is Mitra suppression?
What is
Mitra suppression? Is the combination of extraperitoneal lymphadenectomy along with the shortest radical vaginal hysterectomy.
Okay.
Extraperitoneal abdominal lymphadenectomy, bilateral pelvic lymphadenectomy combined with shortest radical vaginal hysterectomy.
Absolutely.
That is Professor Subodh Mitra's operation.
We are also talking about the less radical surgery nowadays. So can you share a light on that? Less radical
Yes,
surgery.
yes, madam. There are some trials, shape trial and concept trials. In case the tumor size is less than 2 centimeter, there is no LVSI. There is any grade of squamous origin or grade 1, grade 2 adenocarcinoma origin. There is negative node and negative metastasis. In that case, madam, we can go for a less radical or simple hysterectomy approach rather than a more radical approach, which has much more morbidities.
Even stage 1A, 2 and 1B1, we can go for conization also. Some studies have shown fertility sparing surgery.
Absolutely.
What other trials are there? Apart from this concept trial?
Shape
trial, sir.
Less radical surgery.
Shape trial.
Yes.
Shape trial.
And role of sentinel node in cervical cancer.
The role of
You name the trials first. What are the trials?
Centicle 1, Centicle 2, Centicle 3.
Centicle 3 is on.
Centix.
And you know the PROSEC trial? Using only, those were to dual dye, and this one is with only ICG PROSEC.
Sir, I have to study in detail. That I know about the blue dye and the radiotechnician dye along with the ICG green is now, but I have to study thoroughly, sir. That is
Okay, no problem. So before this, you have told you have done a C1, no? Type C1?
Type C1 radical hysterectomy. Yes.
Okay, what are the different types of and who coined this C1, C2? Who?
Yes.
After whom it is?
Professor Denis Coelho from France.
Okay.
Who are other scientists' name? Only Coelho?
Professor Moro. Professor Coelho.
Yeah,
Moro.
you can. It's as per Coelho Moro. Both.
Coelho Moro.
What is the difference between simple hysterectomy and type A radical hysterectomy?
So in simple hysterectomy, we will not address or see the ureter, but in type A hysterectomy, we will see the locate the ureter. There is no such mobilization of the ureter, but the ureter is under vision.
So that has to be done in shape trial and conserve trial, not simple hysterectomy.
Yes.
Okay, so what are the types of hysterectomy? They were originally asked by Dr. Devabrata. Yes.
So there are the hysterectomy are the from the pivot classification.
It's type 1, 2, and 3. And from Coelho classification, it's type A, B, and C.
A, B, C, D.
And again, C is C1, C2, B1, B2.
What is B2? B1, B2.
So B1, B2 is in that case the lateral parametrium is addressed up to the
ureter.
Internal iliac medial side of the iliac vessel. The paracervix is
parametrium is removed up to the internal iliac
up to the medial of the medial side of the internal iliac vessel.
Okay, and others? Rest?
Rest in type A, that is the
A
medial
is
to the
medial
ureter.
to the
Type
ureter.
B is
Type B is the where the ureter crosses the internal ileal artery or up to the ureter, and type C is the beyond that. But type C1 is mainly nerve sparing. As we all know that the inferior hypogastric plexus has the three main supply to the uterus, to the rectum, and to the bladder. And previously it was seen that due to the radical hysterectomy, we used to get many patients with urinary retention or with fecal difficulties or fecal retention and sexual dysfunctions. And to prevent all those things, nowadays we just cut only the uterine branch from the inferior hypogastric plexus, and it's the type C1. So the rest two branches are preserved to
So
reduce
most
the
preferred is the C1, right? Most preferred is the C1. Okay.
Yes, sir.
So tell us about some postoperative complications, intraoperative complications, and immediate postoperative complications of C1. Only C1. Focus on C1.
Okay. Sir, intraoperative complications is there might be vascular injury, there might be ureteral injury, there might be the nervous plexus injury itself. And
Which nervous plexus?
Inferior
hypogastric plexus, or even pelvic splanchnic nerve might also get injured during the dissection. And deep uterine vein injury, that is the most common vascular injury. And ureteric injury and
to the great vessels at the time of lymphadenectomy
also, and bladder injury, rectum injury. All the possibilities are intraoperative. And immediate postoperative period, bleeding,
immediate postoperative
UTI, bleeding, and postoperative.
Immediate postoperative complication, there is chance of primary and secondary hemorrhage. And for the delayed postoperative complication, there is chance of bladder dysfunction, lymphedema, lymphocyte formation, prolonged lymphoria. We have seen prolonged lymphoria.
After lymph dissection.
Commonest site of ureteric injury during the surgery? Or what are the different sites where you can injure?
Ureter can be injured at the time when if we remove the ovary out, then at the time of the infundibulopelvic ligament, at the time where it crosses the uterine artery, and at the time of the ureteric tunnelization, and at the time where it is entering into the bladder. There are four sites that is ureter can be injured.
What is
how can you prevent? Sorry.
So, madam, proper visualization of the ureter at every step where the ureter can be injured. That is the most important point. During IP ligament transaction, we have to do it under proper visualization and separate the ureter. During the uterine artery at the origin or where it crossing the ureter, there is also the proper visualization of the ureter. Less use of the electrocoagulator machines, rather to use the loop, tie the uterine artery, and same thing
during the
at
tunnel
the tunnel dissection
also,
at the
and no blind dissection during uterine.
Do you use fluoroscopic help? Do you need or use fluoroscopic help during the procedure?
We don't
have
that facility.
No, sir.
Any role of ureteric stenting?
No.
Ma'am, in intra-ureteric stenting we have not used, but there is role. At the same time, there is disadvantage that if a stented ureter is not as much mobile or as much malleable than the non-stented ureter.
Yes.
So sometimes it can make it more prone to injuries.
Yeah.
More prone to injuries. So better if we think the chance of ureteric injury, we will stent it post-operatively.
Intraoperatively or?
Intraoperatively, we will stent it.
Correct.
So how long do you keep the catheter on? When do you discharge the patient?
Sir, as it is type C1 radical hysterectomy, we don't keep catheter, or else, sir, we keep catheter for 7 days minimum.
And after removal, we always check for the post-bed residual urine. If residual urine is less than 100
ml or 100 ml,
then only, and the patient has no problem in passing urine, then
it's discharged.
So
what is the rationale of checking residual urine?
Yeah.
Madam, it is done by ultrasound, and it can be done on bedside also by just telling her to pass urine and then catheterize. And
why you are checking residual urine? I am asking, bete, why you are checking residual urine? Why you have to check residual urine?
Because the bladder because there is chance of loss of bladder function because of the nerve injury.
Okay. So all good things have to come to an end always. That's the rule. And I am very much pleased to see the discussion going on a case of looking like fairly straightforward cancer cervix to this level. And immense thanks go to all our faculty members. Dr. Bijal, excellent. Dr. Ranjit Mondal, my dear friend. Dr. Kamna Datta and Dr. Devabrata Varman, and last but not the least, Dr. Ashok Kumar Padi. I think you all have done wonders in this case discussion. And our students, what to tell about them? They have presented the case beautifully. They have faced the crossing with brave heart, and they have continued. But remember, they are postdoctoral trainees. They are not postgraduate trainees. Okay.
True.
So in all MS Gynae examinations, we will not be able to see them. Okay. So this is a next level discussion or a higher level discussion. And I believe I'm very happy. With immense thanks to all of you, and with the care of the ureter still looming large in our mind, the gynecologist's mind, I'll leave this session now, stop this, and invite for the next session. Thank you very much, all of you.
Thank you.
Thank you so much,
Thank
sir.
you.
Thank you so
Thank
much.
you.
You have done a wonderful case discussion. Thank you so much. Well, so, Hafizur, are you there? Hafizur, are you there? I think Hafizur is not there. So I will do the pleasure of, inviting our next speaker for the session, which is called the Master the Technique. So according to NMC guidelines, we have developed this schedule program according to the NMC modulated curriculum that you have to learn the technique, master the technique. And under this theme, we have the topic today of opening and closing the abdomen. And I was told that it is to be restricted for a case of cesarean section, right? So I would invite Dr. Latha Chaturvedula. All of you know her. She's a very renowned professor at Jawaharlal Institute of Postgraduate Medical Education and Research, JIPMAR, Pondicherry, now called Puducherry. And to do justice to this case, Dr. Latha, the floor is yours. Please share.
Yeah, thank you, Dr. Ashish and Hafizur. I didn't know it was only for cesarean. They told abdominal open and closure.
Okay,
So
okay.
I'll just
No
show
problem.
some
As you
videos,
feel
so,
this thing, as you become comfortable, no problem, no problem.
yeah. And thank you for giving me this opportunity. Back again to this. I'll just share my slides. Is it visible?
Not yet.
No, I've shared.
Now it is visible. Make it full screen, please.
Yeah. One second. I'll just. This is always a problem. 1 second.
Yeah.
So
Yes.
thank you for giving this opportunity. So what I have got, the topic is incisions and closure of abdominal surgeries. Okay.
Good to go,
So,
Dr. Latha. Yes.
Yeah. So this I'll be talking about the types, indications, suture material, incision, suturing, and complication. Because when we talk about abdominal incisions, opening and closing, all these are definitely very important to know. So when we talk about type of incisions, all of you know, just both vertical and transverse. Both vertical and transverse can be used for cesarean sections. So in vertical, we have subumbilical, we have supraumbilical, and we have paramedian. And we talk about transverse incisions. I'm talking about the routine things. I'm not going to take the history and historical names. I'll make it very simple. Transverse, we have Phanon-Steele or Joel Cohen, Maillards, and of course, mini laparotomy for tubectomy, which I'm not going to talk much. Why vertical? In vertical, mainly we use for malignancies, especially for ovarian cancers. And if fibroids are big, where it is more than 24 weeks size. Low transfers, usually for cesarean sections, we use low transfers. We go for vertical and cesareans when, especially we are dealing with placenta accreta, or when there are lots of additions where lower segment is definitely not approachable. In those cases, we can use vertical for cesarean section, but most commonly the incision uses low transfers, even if you have a previous vertical incision or fibroids or any other uterine pathology. Mini laparotomy you use for tubectomy. Nowadays, we hardly use Maillard's incision, which was used for radical hysterectomy earlier. So when we talk about incisions, if you see this is the umbilicus, and this is the incision we give, just suprapubic and below the umbilicus. This is the subumbilical incision, which is the common vertical incision. Now, if you go to the next, this is an incision where it has extended above the umbilicus. These types of incisions, if we use for cesarean sections, earlier they used to do classical cesarean section, we don't use anymore. But as I said, if there are dense additions, abdominal additions where the lower segment is not approachable, or whenever we are doing case of placenta accreta, it is always preferred to use a vertical incision, which we may have to extend up. And of course, in all those surgeries where we have to explore the undersurface of the diaphragm and liver, this is in ovarian tumors, we use this kind of incision. Now, this is a paramedian incision, which again is definitely not used anymore. And if this is just the level of pubic symphysis, this is what is fan and steel. Fan and steel is nothing but a low transverse incision, which is like a smiling incision. Again, this usually is not as common, and it comes almost onto the mons pubis. Whereas when we talk about incisions, this is what is Joel Cohen incision, which commonly is used. This is little bit above the mons pubis. This is commonly used for cesareans too, and any of the abdominal surgeries. So this is the compilation of all the types of commonly used incisions. So coming to differences in fan and steel, everything is transversely open except the peritoneum, which is open vertically. Here we do not cut the muscle, we only split the muscle. Whereas in Maillards, even peritoneum is open transversely. Here we cut the muscle means we talk about the abdominal muscles, which is external abdominis muscle, and we definitely cut it and then make an incision. We cannot split the muscle. That is the rectus muscle. So coming to why vertical, it is easy to give. Upper abdomen is very easily approached, and of course, but complications are a bit higher, like infections and incisional hernia. In transverse incisions, it is more cosmetic, very comfortable for the patient, especially in the post-op period. Complications are less, pain is definitely less, but cannot be given in bigger masses. And there is a slightly increased chance of bladder injury because it is quite low down, especially if there are previous additions. Now, coming to general principles of surgery, usually surgeon, preferably they stand on the left side. This is for a right-hand surgeon, but most of the time I see people stand on the right side on operate. It's mainly for comfort, but always prefer to stand on the left side. Assistant will be on the right side. Assisting nurse will be on the side of the surgeon. Follow the WHO checklist, and vertical incisions, usually all the layers of the abdomen are opened vertically. Now, what is the WHO checklist? Introduction of the team members, both from anesthetist side, from the surgeon side, and also from the nurses side. Sterility checklist, in which we see certain things like site of incisions, whether the prophylactic antibiotics are given or not, and of course the anticipated blood loss and what complications are anticipated, both from our side and also from anesthetist side. When we talk about sterility check, even nurses will have to tell about whether all the sterile precautions have been followed. And finally, we also talk about approximate time for the surgery. So this is in brief about the WHO checklist. So what we do when we make an incision, we make a skin incision, whether it is vertical or transverse, the layers which are cut are almost the same. And then you cut the subcutaneous tissue, in which we need to check for the bleeding vessels. How do we cut? We can use a scalpel or we can use a cautery, whatever is available. Most of the people prefer using a unipolar cautery, and either use an instrument to cauterize vessels, or we can use a bipolar cautery to cauterize the vessels. Then next is the rectus sheath, peritoneum. When we are opening the peritoneum, we should be very careful. Lift the peritoneum, feel for any bowel or anything is felt, and then make an incision. And don't hold the forceps too close. Otherwise, there is a chance of bowel injury if it is inadvertently held. As I said, we can use either scalpel or a cautery. So these are the usual instruments which we require for doing any surgery: a scalpel and a monopolar cautery, bipolar also. Then we use various scissors. See, the scissors should be used specifically for specific tissues. Straight scissors is used only to cut the suture material. This is the Metzenbaum scissors. Metzenbaum is a thinner version of a curved scissors, which is used to cut thin structures like peritoneum. Then again, one more straight scissor, and we have a Mayo scissors, which is a slightly broader one, which is used to cut the thick structures like the rectus sheath. Then you need Alice forceps. Alice forceps is used to hold thick structures like the rectus sheath. And we use straight instruments. This is the straight artery forceps, which is used to hold the peritoneum. Then we have the Zernis forceps, Zernis retractor. This end, when we are cutting, this end is usually used so that when you are cutting, you can go a little bit beyond and cut between. This end is used when we are suturing the tissues. When we use this end for suturing tissues, the suture material may get entwined around this inguinal arms. So we don't prefer using that end. But this is definitely used for opening the abdomen. Then these are the other instruments required for suturing. As I said, this is straight, you need to hold the peritoneum, and Alice to hold the rectus sheath. Tooth forceps to hold the tissues. This is the needle holder, which has a latch, and there is a small groove to hold the needle, and the artery forceps in case there are arteries which are spurting, we need to hold them. So coming to suture material, this is a chromic catgut. I don't know how many of you use. Those who close the peritoneum still use it. It is a 10, either we use 10 or 20 chromic. Earlier for cesarean sections, people used to use, one catgut. I still use. The advantage of chromic catgut is it's absorbable, fast absorbable, and also it is a monofilament. Usually infection chances are less. Then this is the proline. Proline is used. It's a monofilament again. This is used. It is basically a polypropylene. It is used to suture rectus sheath. We have various, this thing is called 101, depending on the thickness. The more the zeros, the lesser the thickness it is. We usually use this to close the rectus sheath. Number 1 can be used. We can also use Vicryl. Vicryl is nothing but it is glycolate with lactite. It is again a braided, but then the disadvantage is it is braided, but advantage is reaction, unlike proline, is less because it is like a cotton and it is delayed absorbable. This also can be used for rectus sheath. Nowadays, this is the material which is used to close the cesarean wound, that is the muzzle of the uterus, right? So now coming to, that is how to close the, finally we have to close the skin. Skin, we can use various things. We can use silk if you are putting interrupted sutures. People use staplers, and we use monocryl. Cesarean section, usually we prefer, or even simple hysterectomies, we usually prefer using monocryl. It's available, but it is costlier. The advantage of monocryl is, first of all, you don't have to remove. It's very comfortable for the patient and it is absorbable. And the sutures come very nicely when we use monocryl. Staplers, usually for malignant surgeries, either the staplers or skin are used. Only problem with staplers, you can't send off the patient and ask her to get the suture removal done elsewhere because they may not have the stapler removing equipment. But otherwise, any of these things can be used for skin. For benign surgeries, for cesarean sections, always prefer to use something which is absorbable and we don't have to remove. We can use Vicryl Rapid, we can use thinner Vicryl also for closing the skin. If you look at the tensile strength of the suture material, plain catgut obviously lasts for 3 weeks. Then chromic catgut, we hardly use plain catgut. Chromic catgut lasts for 4 weeks. Then we have Vicryl. Vicryl almost by 6 weeks it gets absorbed. PDS will always remain, and also proline will remain. So I'll just show some few videos, not very great, but yes, I just happen to do. So this is the incision where we give subumbilical incision. So go up till the mons pubis. You can use the cautery. This patient had some bleeding disorder, so she was bleeding a little bit more. Sometimes problems will be there that cautery may not cut. So we can use a knife, which we are more comfortable with. But when you use a knife, there may be some extra bleeding. So that you'll have to cauterize. Keep mopping and cauterize. Either you can directly cautery or hold with the artery forceps or the thumb forceps and cauterize the abdomen. So next we are cutting the rectus sheath. Be careful. Sometimes if previous surgeries, bowel may be very close, so you should be careful, especially if they have not closed the peritoneum prior. So always the technique is lift up and cut, so that you don't cut any structures below. Sometimes scissors doesn't work, then you have to change the scissors, or you can use the cautery. Keep mopping and keep the field bloodless, which is more important. Sometimes this upper abdomen, you have this thing which is stuck, so you may have to put the fingers or put the artery forceps and then cut. Otherwise, you may cut tissues below also. So this is opening of peritoneum. Make a small incision. Always try to see if the bowel, sometimes may not be visible. So always keep the bowel a bit, which is very important. Either we can take and cut with the scissors, or we can cut with the cautery. Lower part, sometimes you'll have lot of fat. You don't know whether it is the bladder is adherent. So you should be careful while cutting. When you're using cautery, be careful that there is no bowel below. That's very important. And there'll be a lot of fumes. You can always do suctioning of the fumes. So this is the closure. I mean, some people prefer using closing the peritoneum. I always prefer closing the peritoneum with catgut. Here, this was basically this surgery was a surgery done for malignancy. So they are closing with rectus sheath. You may see some people are using hand. Actually, that's not correct. We should hold the tissues with a tooth forceps. If it is peritoneum, you can use the non-tooth. If it is rectus sheath, you should use the tooth forceps. The disadvantage of not closing the peritoneum sometimes is the bowel may get stuck to the rectus sheath, and sometimes you may inadvertently take the bowel into your suture. So always put a finger and make sure the bowel doesn't come into your suture line. And lift up. The most important principle is always lift up the tissues and suture. Once you lift up, what happens? The bowel or whatever structure is momentum will fall back, so that they will not come into your suture line. So this is not a correct technique using finger. They should always use a instrument. We always hold the rectus sheath with Alice. And here what we have used is a double braided, not braided, double string proline, so that we tie and then cut it. So that is the video for this thing. Sorry. So this is transverse incision, where we are given, this is actually for cesarean section. There are various ways of cutting. Some people cut this and extend everything with the hand, make a small nick, and rest of it we extend with the hand, the whole thing. Or some people cut the entire thing with using instruments. So you just extend the entire this thing, sorry. So that is a incision made for cesarean section. And everything is open transversely except the peritoneum. Peritoneum will be open vertically. The same thing. So next, this is the closure. So here we are closing the peritoneum using catgut. So again, as I said, peritoneum will be closed vertically, except in malars, where we open the peritoneum also transversely. This is the rectus sheath. Always, I mean, most of us prefer putting a continuous incision unless you're expecting a lot of infection like chorioamnitis or something like that. In those cases, we can use interrupted sutures, but otherwise we can use continuous sutures like this. But intermittently, we can knot the sutures with the same thing. If the subcutaneous tissue is not very fat, then we can just close the skin. Sometimes the patients will have lot of subcutaneous tissue, in which case we prefer putting a drain. Lot of times, if you have not put the drain, it has given way. Put a small, Romovac drain, or what we use is a Riles tube, and we connect to the syringe. We put the drain and then close the subcutaneous with the catgut or sometimes even monocryl. If you are rich or you have adequate resources, you can use monocryl. Otherwise, 1-0 catgut is good. Either you put interrupted sutures or you can put continuous sutures for the catgut. We don't prefer using vicryl, and this is how we are closing the skin with monocryl. Monocryl is very, very comfortable for the patient. Only thing is you should make sure that the skin is approximated properly and there should not be overlap. Where we take incision is along the line, the subcuticular region, that white line. It's very comfortable. You don't have to remove, and the patient can go back on the second day. Usually cesarean sections, maximum we discharge them on the third day unless they have some other morbidities or something like that. Otherwise, even hysterectomy, this is a very comfortable material. Patients go back on day 2, especially if they are from local place. So once you have done that, come out and then keep it. So that's how monocryl is put. Very, very comfortable for the patient. So the problems which are encountered during surgeries, usually scissors. They are not sharp enough. They don't cut. We tend to waste a lot of time. Yeah, we can't help it. So make sure that we get a cutting scissors, get them sharpened often. Sometimes cautery does not work for various reasons. Even the new pencil does not really cut. You have to make sure the settings are proper. Whenever there is previous fibrosis of the tissues, difficulty may be there in opening the rectus sheath, lots of additions. You may have to try to get some windows where we can open. This commonly happens with cesarean section, previous 2, previous 3 cesarean sections. That's why we tend to make higher incisions. Okay, we can use bipolar or monopolar cauteries to cauterize tissues. But cesarean, you should be very, very careful, especially when the baby is still in situ to use. Many people still do open the abdomen using cauteries, but we should be very careful, at least till the baby is delivered. Later on, maybe you can use for cauterizing the bleeding points. Sometimes, abdomen, when you're opening, the subcutaneous tissue keeps on bleeding in spite of cauterizing. So sometimes just holding with an artery forceps and crushing and leave it there for some time will help achieving hemostasis. We have done so many times, after that it just stops. So it basically needs to be clotted. So those, while opening peritoneum, always feel for the peritoneum, whether there is any bowel, and then hold it, feel it, and then cut. Always lift the peritoneum and cut. Even for while suturing, we should lift the peritoneum and then suture. Same thing with the rectus sheath, especially if you're not closing peritoneum. When I'm saying peritoneum, we're talking about parietal peritoneum. Usually we do not close the visceral peritoneum. Then as you're suturing, you can feel the suture line from inside to see that there is no bowel. It's better to be cautious before, rather than having a complication and then having a fecal fistula and treating them. The morbidity and mortality is so very high. So this is how I said, you have an incision like this, put your finger, lift and see if any bowel or something is there. Usually this problem is encountered in the upper abdomen. As we come in the lower abdomen, peritoneum is pretty loose and we don't really face such a problem. It's always the closure problem is in the upper abdomen. So complications, hematoma, many a times, if you have even, after closing the rectus sheath, above the rectus, there may be a lot of bleeding. Make sure we have achieved the hemostasis either by cauterizing, or sometimes you may have to take some sutures. Make sure, especially sometimes the inferior epigastric, if it gets injured and we have overlooked it, there will be a problem. Injury to the viscera either during opening or closure of the abdomen, especially when we are opening the rectus sheath, and previously if you have not closed the peritoneum, there's chance that the bowel may be adherent. So this should be very careful. So as I said, lift the tissues and then cut. Infection is a problem. This can be tackled by giving prophylactic antibiotics. When I say prophylactic, it's only a single dose. Continuing for the 7 days or whatever period of time is not prophylactic. That becomes therapeutic. Other complications are wound breakdown, and of course, infection control is scrub properly, use all the proper procedures while scrubbing. and also clean the patient properly, make sure the patient takes bath. All these are small things, but they make a lot of difference in preventing infection. There may be wound breakdown, again, secondary to infection, or sometimes what happens is these small hematomas, we can have wound breakdown, and later complications, we can have incisional hernia, more so with vertical sutures. Whenever you think there is a chance of giving way, especially if the patient is very thin or she has comorbidities, it's okay to use interrupted sutures even for rectus sheath. Only thing is you should invert so that it won't irritate the abdomen. So to summarize, incision depends on the indications for the surgery. Even at cesarean section, though the most commonly used incision is the transverse incision, but sometimes, as I said, we may have to use a vertical incision when we have adherent placenta or when adhesions are too many, or sometimes we have done in situ cesarean section with cervical cancer. In those cases, you definitely have to do vertical incisions, though we don't see that commonly nowadays. Do not be in a hurry. Take your time and see structures properly and cut. We need to achieve hemostasis while opening and closing the abdomen. Use energy sources judiciously but effectively. Thank you.
Perfect, Dr. Latha. Thank you very much for a very clear, lucid, short, but very, very effective lecture
Thank you.
on
Thank you.
opening and closing the abdomen. And I believe that the students have learned a lot of things from this simplistic discussion. Thank you very much for keeping it simple and
Thank you,
letting our students know what this opening and closing of the abdomen, the technique, the suturing materials, the time, the patients, the adherence to the complications, everything has been cleared from your lecture. Thank you very much. I
Thank you,
just have
sir.
one question, madam.
Yes, sir.
Most of us today, they do not prefer closing the peritoneum, even the
Yes.
What is your take on that? You seem to routinely close the peritoneum.
We are used, I'm a little bit old timer, but I have seen lot. The problem is when you're taking the rectus sheath, people are very careless. We have seen the bowel coming, the omentum coming. That is the thing. So that's what you close. And I have found whenever I have never had wound breakdown, luckily, because of these things maybe. But the thing is, present generation are in a hurry. There's this thing. So I think it's all about the technique, which is important. I am somehow very comfortable closing the peritoneum.
So
Just
actually,
that.
I also belong to the previous generation, so-called previous generation, where we used to see closing the cesarean section wound. My teacher, Professor B.N. Chakravarti, he used to close the uterus in 4 layers, 1, 2, 3, and 4 meticulously. Close in the peritoneum also in the. But since then, we have come out of it and we
Yeah.
do
Visceral, definitely not. Visceral, we don't close both at hysterectomy, not, but parietal, I'm still very whenever we are doing malignant surgeries or the peritoneum is very difficult to close, then it's okay. But usually I'm comfortable closing peritoneum just because I've seen a lot of burst abdomens, I've seen wound gapings, especially, when they take off. It's not that it's not possible with peritoneum, but then when you're closing rectus, when you're closing peritoneum, you're more careful, I feel. When you're closing the rectus without peritoneum, we just casually tend to take, as you have seen this. So, that's just, what the comfort zone.
And in rectus sheath, we prefer to use the PDS because it stays in the tissues. And I think Vicryl is also a good choice. But after some time,
Proline, we use proline.
Yeah.
I prefer proline because it's a anything monofilament I prefer because Vicryl, the problem with Vicryl I feel is it doesn't get tightened fast. The people have to really tighten it. Otherwise, especially when you're doing hysterectomies and all, with our kind of residents who don't, learn knotting outside, it becomes difficult. But of course, nowadays proline is the thing for everything. But somehow I'm comfortable with proline and not Vicryl. So Vicryl is good, but PDS is also good. Depends on what is available in your
the
institute.
tensile strength is
PDS.
good. The edema, inflammation, tissue
Yes,
reaction
very less.
less with the Vicryl. Yes, Vicryl is.
Even when it comes to staplers, actually, many times I've used, even for vertical incisions, I've used this monocryl. It fantastically closes.
Yeah.
I should not be telling that, but it's okay for benign conditions where, but provided you have closed the subcutaneous, you can use the same monocryl to close the subcutaneous.
We use
But it
Vicryl
is,
Rapide for
yeah.
this thing, subcutaneous.
I don't know, this is my personal thing. With Vicryl Rapid, I've had a lot of infections. So we literally stopped using Vicryl Rapid, but monocryl is
has
good.
infection, right?
Yeah. So otherwise, you can use simple Vicryl also, 10 or 20. 20 Vicryl is good for skin, subcutaneous. Yeah. But Stay Plus, again, people should put it properly. Otherwise, the chance of wound gaping is quite, I mean, people should learn to use. It has to be approximated properly. You need an assistant for monocryl. When you're putting any subcuticular, you can do it on your own. You don't require someone to assist you.
So with a lot depends on the availability of material in the resources.
Monocryl is definitely expensive.
It is expensive.
I agree. Staples are also expensive.
So thank you so much, Dr. Lata. It was excellent lecture, and I believe that the students will all be benefited. And those students who have missed today's lecture, our lecture, it will be available in the ICOG website. So do revert to it and listen to her lucid lecture. Thank you very much, Dr. Lata.
Thank you so much. Thank you.
So with that, now we come to the last session of the day today, and that is a beautiful quiz organized by the quiz committee of FOGSI, and we have amongst us Dr. Archana Kumari, chairperson, FOGSI quiz committee. Is Archana here?
Yeah, I'm here, sir.
Oh,
Good
yes.
afternoon.
I can see the lovely face of Archana. Yes, so good.
Thank you so much, sir.
And with her, we have Dr. Deepti Gupta, West Zone FOGSI quiz coordinator. And
Good afternoon, sir.
And good afternoon. Both of them together, they're going to do a quiz on the cervical cancer. As we said, ICOG has decided to pick up one theme topic every month, and they will conduct the quiz. So nice of you, and so good of you to select your quiz questions on cervical cancer. And we would like to involve more and more students. We have circulated this widely. Let's see how it goes. And they use an app, all of you know. I think, Archana, you can start your session quiz right now. Thank you so much.
Yeah, good afternoon, everyone. It's a proud privilege given to us by ICOG Chairperson Dr. Parag Miniwala to host a quiz on theme subject every second Sunday of the month. So this month we have quiz on cervical cancer. And I have with me Dr. Deepti Gupta, West Zone Coordinator of Quiz Committee, an excellent quiz master. She has worked very hard for this quiz despite her personal engagement. So I think she has already started sharing the screen. The quiz is going to be conducted on Kahoot. And last time we had some problem in getting the participants logged in. So this time we widely circulated the methods or the steps to join Kahoot. So over to you, Deepti. I think you have already shared your screen.
Yes, ma'am. I have shared the screen, and meanwhile, I think we would probably just give the instructions once again.
Yeah.
So all the attendees who are in today's excellent program, I was listening in from the beginning, and really grateful to Ashish sir, Hafiz sir, for giving us this prestigious opportunity. And some of the participants have already started joining in. So dear students, there are 2-3 ways by which you can join. I am also sharing the link in the Zoom chat box. So those of you, if you have any trouble, you can simply click on this link that I'm putting in the chat box. There you go. Otherwise, you can download, if you have the Kahoot app already on your phone, enter the game pin 3630061, or you can go to your browser, whatever browser you're comfortable with. Just type www.kahoot.it and then enter the game pin, and you will be taken in this game zone. And we will keep the quiz open. We will not lock it. The game pin will be on display throughout the quiz. So even if you join in between, it is absolutely okay. And a plus point is that those of you who were tuned in from the beginning, a lot of points have been discussed in the phenomenal case presentation by Dr. Anvesha and Dr. Anirban
guided very, very perfectly by Ashish sir, Bijal madam, Devabrat sir, Ranajit sir, and Kamna madam. So I am sure it is going to be a very, very engaging quiz. And the organizing team is also going to gift books to the top 3 winners. And ma'am, when would you say we start? We have about 43.
I think how many people have logged in?
Ma'am, 42 have joined in the.
Yeah, so I think we can start. Last time we could have only 25.
Okay.
So-
So I'll just wait for last 10 more seconds. Once
Yeah.
again, you can click on the link that I have put in the chat box, or you can enter this game pin in your Kahoot app. या फिर simply open a browser.
Yeah, some of the students have joined like PG or something. You be specific about your nickname, no? SB, because at the end it will be difficult for us to know who at least you write your name.
Yes, all those who have entered, see, there are two things. If you do not want to be identified or be given the prize if you reach the podium, then it is okay. You can enter with your, just initials. But if you want to be given credit and recognized for who you are, and if you want that we should be able to share the prizes with you, then we would appreciate if you enter at least the first name and initial with it. Ma'am, we have 50 participants. I think with your permission, I'll start the quiz.
Yeah, please start.
Okay. So the first round would be conducted by our quiz committee chairperson, Archana Kumari ma'am, who was kind enough to trust me with this opportunity. And I am starting the quiz now.
So here we go, 3, 2, 1. We have the ICOG PG clinic, and myself with Deepthi are the quiz masters, and this is the time for action. I hope I'm audible because I'm at the airport.
Yes, ma'am. Yes, ma'am, you are.
Okay.
So should I go to
this
the first question?
Yeah, this is the important milestone round. That is the round 1. Yeah, first question. Identified this famous scientist credited with invention of colposcope. So you can read the choices yourself. Sometimes you read at a faster pace than me. So I'll just let you read the choices. Hinzelmann, Papenkolau, Hippocrates, or Hussein. Actually, I'm logged in through mobile.
Yes, ma'am. The font size would be very small.
Yeah, that's why.
So last 3 seconds.
Yes, Hinzelmann was the correct answer. Most of you have got it right. That's great. So on the scoreboard, Preeti is at the top. Let's go to the next question. Name this Nobel Prize winner who found HPV DNA in cervical cancer and genital warts. So I think you can read the choices yourself. And you have the picture also, image of the person also. So the correct answer is Hussein, and most of you have got it right. That's great. That means you people are prepared very well. And again, I think there's slight change in the scoreboard. That's what we were telling. Deepthi was also telling AKB. We cannot identify you. But anyway, let's go to the third question. First HPV vaccine was approved by FDA in 2006, 11, 5, 8. So this year, our president's FOGSI presidential initiative, Do Tike Zindagi Ke, we are working hard on it. And I think you should also, the PGs should also be aware of it. And so you must know about this question. Yes, most of you got it right. It is 2006. The scoreboard remaining same. I don't know who is AKB, but he or she is the top. Next question: which day is celebrated as Cervical Cancer Elimination Day of Action? 4th February, 17 November, 4th March, 27 July. Yes, it is 17th November, and I think the most of them are getting right. The highest percentages of right choice only. So that shows a good preparation and good dissemination of topic well ahead. So now again we have change in scoreboard. KA is now at the top. It would have been better if you would have identified yourself with your name. But anyway, next. 8th standardized incidence rate of cervical cancer in India for 2016 was estimated at, you can read the choices on your own. Still have 10-12 seconds to go. So the correct answer is 12.1 per 100,000 women. And again, the highest percentage is of correct answer. Let's see the scoreboard. Now there's change again. Paritosh Gupta is now at the top. Let's go to the next question. Risk factors of HPV screening.
And this is the next
Oh, this is
round.
the
There's a
round
change.
2. Okay,
Yes,
okay.
yes.
So round 2, I hand over to Dr. Deepti Gupta. And Deepti, you can go ahead. At the end, I will just request you to take the screenshot of the
Of the
winners.
podium. Yes, ma'am.
Yes, podium.
ma'am.
So I might have to log off because the boarding is being announced.
Sure,
Thank you
ma'am.
so much, Deepti, for taking so much pain in preparing the question, putting it on the Kahoot. All the best for the rounds.
Thank you so
Please
much,
go
ma'am.
ahead.
Thank you so much. So we will not keep the contestants waiting, and moving on to the next few questions. Here we would be talking about various other factors. Now, which risk factor is not known to increase the risk of both squamous cell carcinoma and adenocarcinoma? We know that HPV, lower socioeconomic status, cigarette smoking, sexual activity, all of these are implicated risk factors. But there is one which does not increase the risk of both. Which one is it? And the correct answer, wow. All of you are really very, very well prepared. So cigarette smoking is one risk factor which is associated with increase in squamous cell carcinoma, but not in that of adenocarcinoma, while all others contribute to both. So looking at the scoreboard, Paritosh continues to lead with many players having an answer streak. Next question, this also should be an easy one. Which HPV strain is associated with over half of the cases of adenocarcinoma? Is it 16? Is it 18? Is it 31? Or is it 33? We know that HPV has many subtypes. Some are high risk, some are low risk. But which one is it which is most commonly associated with adenocarcinoma? And the correct answer was HPV 18, which again, almost half of you got correct. And the other half who got confused, we don't blame you. Just remember this. Because see, what happens is that whenever in future, now we are in the times of HPV based testing and triaging. So whenever the report comes, you need to keep that in mind and counsel and monitor the patient accordingly. So looking at the scores, R. Patnaik is back on top 5, followed with Ash Paritosh, AKB and others.
Dr. Deepti, I think we have lost you because you are muted.
Yes, sir. Yes, sir. Sir, I think I lost my connection in between
Yeah.
transiently.
Maybe, yes. Maybe we lost your connection also.
Yes.
Because in the
So,
middle, some brief period, you were not audible nor visible.
yes, sir. Yes,
That
sir.
is
So
better
no
now.
problem. I think this question is okay because nobody, none of the answers were logged in. So we'll move on to the next question.
Okay.
And Paritosh continues to lead the scoreboard.
Ma'am, your screen is not visible.
Okay, just a second. I'll wait for one question to get over, then I will start sharing.
Okay, ma'am.
I think the participants are already playing. Wait. Yes. Now it is?
Not yet, it's loading.
It's coming. Yes, loading.
Yes.
Yeah,
Now
it's
it's visible.
Okay. So, which is not a component of the 90-70-90 strategy was the question. And very happy to see that half of the students have gotten it correct. So, actually, the 90-70-90 strategy says that by 2030, we need to target 90% vaccination in girls under the age of 15, 70% screening in women of the age bracket 35 to 45 years, and treating 90% of cervical lesions. We are not expected to screen women of all age as part of this strategy. Let's look at the scores. So AKB and Paritosh are playing it around, and Khairul is the highest climber. Next question. Which subtype is not a component of the nonavalent vaccine? I am sure the question itself is easy, but just look at the answers carefully before you check in your answer. Is it 43, 31, 18, or 11? Which strain is not a part of the nonavalent vaccine? Last few seconds. All right, so majority got it correct, and I am sure the others probably had some confusion. So this is something we just need to by heart. There is absolutely no two ways about it. So 6, 11, 16, 18, 31, 33, 45, 52, 58 are the ones which are part of the nonavalent vaccine. And we know we have the bivalent and the quadrivalent as well. Bhavya is one of the highest climbers. AKB continues to lead as of now. Next question. 3 doses of HPV vaccine are recommended for age more than 15 years when it is initiated, any age but immunocompromised status, both of the above situations or none of the above situations, just 1 to 2 doses are enough in all situations. So which is the correct answer? We know that routine recommendation is of 2 doses, but is there any place of 3 doses of HPV vaccination? And the correct answer was both of the above. So whenever it is initiated in someone more than above 15 years or the person is immunocompromised, then a third dose has to be given. 0, 1 to 2 and 6 months. So Aparna is the highest climber. R. Patnaik has also moved to the second place. Systematic review and meta-analysis in HPV vaccine outcomes have shown maximum reduction in HPV 31-33 prevalence, HPV 16-18 prevalence, CIN or cancer cervix. Mind you, there has been reduction in everything, but the maximum reduction was shown in which parameter? Last few seconds. And the correct answer is HPV 16-18 prevalence. So this systematic review and meta-analysis confirmed about 83% reduction in the HPV 16-18 prevalence, about 54% reduction in 31-33 prevalence, about 67% reduction in anogenital warts, and about 51% reduction in the incidence of CIN2 and above. Looking at the scores, Aparna is back with an answer streak of 3 and AKB continues to lead. Next question up on your screens. Which screening modality is suitable for SVA, that is single visit approach? HPV testing, pap smear, VIA, all are equally suitable. Which one is a befitting modality for single visit approach? And this approach has actually been listed by WHO for low resource settings. Last few seconds. And the correct answer, as half of you guessed it right, or rather new, VIA. We know that pap smear is a good test, but it is resource intensive, requires multiple visits, may not be feasible at all times. And HPV definitely has a higher sensitivity and accuracy. But then again, the cost factor, the logistics and everything has to be taken into account. And VIA improves coverage and eliminates the need for multiple follow-ups. So let us look at the scores. SB is the highest climber, and I can see AKB sticking to the place, followed by Ramya, Satvi, Preeti, Dipali. Next question, when can cervical cancer screening be discontinued? We know there is a protocol, when to start, how to do. So when can it be discontinued? Women age more than 55 with 1 negative screening. Women age more than 65 with adequate negative screening. Women age more than 65 with any 1 negative screening, or any age with adequate negative screening. So when can it be discontinued? Last few seconds. And yes, it was a giveaway answer. Almost everybody got it right. Women age more than 65 with adequate negative screening, you can stop the screening. Whereas others, see, 1 negative screening is not good enough. Age around 50-55, if there was HPV sensitization or some pre-invasive lesion, she could still develop the lesion. That probably is the logic why 65 with adequate negative screening is what is recommended. BS is making a comeback with 3 in a row. Now we move on to the next set of questions where we would be talking about diagnosis, staging, and management. Which one is not a main change in recent FIGO staging of 2018? Horizontal dimension considered in microinvasive lesion, tumor size given 3 subgroups, lymph node positivity assigns a stage of 3C, all the changes were done in above staging. So which one is not a main change in FIGO staging? Oh, this is interesting. So this we have to remember, please, that the horizontal dimension that we used to read, 7 millimeters or more, that has been removed in case of microinvasive lesions because it was observed that it has no correlation with disease outcomes and survival rates. Tumor size, certainly, we now have less than 2 to 4, and more than 4 centimeters. Lymph node positivity straight away assigns 3C, wherein pelvic lymph nodes positive is assigned 3C1 and para-aortic positive is assigned 3C2. And also we are expected to make a remark of how this lymph node positivity was confirmed, whether it was pathological or whether it was radiology based. And so all changes was actually a wrong option, which was put in there to confuse all of you. And AKB continues to lead. False about staging of cancer cervix is: first staging was proposed in 1958. FIGO 18 staging permits the use of imaging modalities. Cystoscopy colonoscopy is to be done in all, and clinical stage once assigned is not changed. Which statement is false about the staging of cervical cancer? Last few seconds. And the correct answer is cystoscopy colonoscopy to be done in all. Actually, cystoscopy colonoscopy is to be done only if a patient is symptomatic. First staging, definitely it was proposed in 1958, followed by the TNM staging. Then we had the 2018 change by FIGO. Clinical stage, and whenever we are in doubt, we usually assign the lower stage. And clinical stage once assigned is not changed. So these investigations are not to be done in all patients. Prerna has an answer streak of 3. AKB continues to lead. This is a true or false question. LVSI, that is the lymphovascular space invasion, alters both stage or stage of the disease and the treatment plan. True or false? The answers are coming in fast. Last few seconds left. And the correct answer actually is false. So, LVSI, it may change the treatment plan, especially with regards to post-operative radiotherapy or any adjuvant therapy which might be needed. But the stage does not change based on the LVSI. So let's look at the scores. AKB is stuck, followed by Dipali, R. Patnaik, Satvi, and Preeti. And 3 players have an answer streak of 4. Another true or false question. Stage 1A1 or 1A2 CA cervix, desiring fertility, conization or trachelectomy may be considered in this subset of patients. This, I'm expecting an all correct answer. So we already have 50 responses with 10-12 seconds to go. Last 5 seconds. And the correct answer, very happy to see this. Everybody got it correct. That if a woman is desirous of fertility, then in very early stages, conization or trachelectomy may be considered. But trachelectomy has to be clubbed with lymph node assessment.
With a seat in front.
3. Yes, ma'am. Okay. So the next question. For 1B22A1, which is not an advantage of surgical treatment, precise post-operative staging, treats the radio-resistant variants, helps conserve ovarian function, or better survival than radiotherapy. So for the stage of 1B22A1, which is not one of the advantages of surgical treatment? Come on, last few seconds, many more responses yet to come in. And the correct answer, again meant to confuse everyone. Actually, both the modalities have equal survival in this stage of disease, but the operative treatment definitely has the advantage of precise post-operative staging. For example, the margin assessment, the LBSI. There could be some radio-resistant variants. We know that there are so many histopathological variants of carcinoma cervix we are aware of now. And certainly there is an option of transposing the ovaries out of the radiotherapy field. So it can help in conserving the ovarian function to a certain extent. So the answer was survival 1. And we have 4 players with an answer streak of 3, and AKB continues to lead. Next question, another true or false question. In stage 1B3 or 2A2, preferred modality of treatment is CCRT, that is the concurrent platinum-based chemoradiation. Is this statement true or false? And again, most of you got it correct, but few of you got it who got confused probably. So as the stage is increasing here, see the word is preferred modality. So the reason being is that the likelihood of lymph node involvement starts increasing as we reach 1B3, 2A2, and which is why CCRT is the preferred modality rather than surgical alone in this subset of patients. A lot of players have answer streak of 3. AKB continues to lead. Another true or false question. LDR, that is low dose rate, high dose rate, or pulsed dose rate. Any of these modes can be used for the intracavitary radiotherapy. Is this statement true or false? Last 10 seconds. And the house is divided on this. Okay, so low dose rate, high dose rate, and pulse dose rate, actually both of them had comparable survival rates. And therefore, with regards to ICRT, any of these modes can be used as there is no difference in the survival rates. So 5 players have an answer streak of 4. AKB followed by Dipali, R. Patnaik, Satvi, and Preeti continue to be on the top 5. Another true or false question. Radiotherapy duration has no correlation with risk of pelvic fracture. Is this true or false? We already have almost half of the responsives. 20 more seconds to go. So is there any correlation with the risk of pelvic fracture and the duration of radiotherapy? And the correct answer, the statement is false. There is an actual correlation. And ideally speaking, we need to target completion of the entire protocol of external beam radiotherapy with brachytherapy within 8 weeks. Because the moment we start crossing the 9 to 10 weeks threshold, there is a significant increase in the risk of pelvic fractures. Dipali has the highest answer streak of 14. Very nice. False about modified radical hysterectomy is, it is known as type A in the Curlo-Moro classification. It can be done for 1A1 or 1A2 stage disease. Ovarian removal is optional. Vaginal margin removal is of 1 to 2 centimeters. Rectum is mobilized below cervix. Partial removal of uterosacral ligament is done. Which statement is false about modified radical hysterectomy? A good number of you got it correct. Actually, it is known as type B. So the Curlo-Moro classification gives us in detail about the various names. type A is the extrafacial or kind of simple, extrafacial hysterectomy. Then B1, B2 is the modified radical hysterectomy. C1 is the nerve sparing radical hysterectomy. C2 is the non-nerve sparing radical hysterectomy. And then we have type D. And there are details also given with regards to how much what is to be dissected in various categories. So 3 players have an answer streak, and I see some shuffling between R. Patnaik, Preeti, and Sathvi, whereas AKB and Dipali continue to be in their places. In case of pregnancy with carcinoma cervix, false statement is: if diagnosed in first trimester, treat without delay. Radiotherapy often leads to spontaneous miscarriage. Treatment may be delayed in 1A to 1B1 if the pregnancy or if the condition is diagnosed after 20 weeks. Classical cesarean with radical hysterectomy can be done up to 37 weeks, which is a false statement in this situation. And the correct answer actually was that classical cesarean with radical has to be done no later than 34 weeks. The idea being that as soon as we are reasonably sure of fetal lung maturity, we need to deliver the baby so that mother's treatment can be initiated without any further delay. And a lot of you who got confused, in first trimester, if carcinoma is diagnosed, then the pregnancy, then malignancy has to be treated without delay. And in early stage disease, if it is diagnosed after 20 weeks, then we can wait after thorough counseling of the couple and the family. Here, Rijuta is making a comeback with 3 answer streak in a row. SEDLIS criteria for adjuvant treatment after radical hysterectomy includes any tumor size with deep 1/3 stromal invasion, tumor size more than 2 centimeters with middle third stromal invasion, tumor size more than 5 centimeters with superficial third stromal invasion, or does it include all of these? So this criteria is available, for deciding after hysterectomy, what is to be done. Very often, as juniors, we see our senior faculty looking at the report and telling, Acha, send this for adjuvant. This patient does not require anything. So yes, this was one of the more of learning kind of questions. So any tumor size, if there is deep third stromal invasion, small tumor but middle third stromal invasion, big tumor with superficial third invasion, then the patient needs adjuvant therapy after radical hysterectomy. SB, good to see you making a comeback. And next question. Incidental diagnosis of carcinoma cervix in a hysterectomy specimen. The stage was 1A1 with LVSI or 1A2. What is not needed? Review of specimen and slides, further imaging, no further intervention, laparoscopic lymphadenectomy of suspicious nodes. See, the patient was subjected for hysterectomy, and in the post-hysterectomy specimen, you received this histopathology diagnosis. So what is not needed in this situation? And the correct answer is no further intervention. We cannot leave this patient because in 1A1, we have a report of LVSI and or we have a case of 1A2. So we certainly need to review the specimen and slides. We need further imaging to rule out other organ involvement, and we certainly need laparoscopic lymphadenectomy. So Bindu is back with an answer streak of 3, and the top 5 of the scoreboard continue to be the same. This brings us to the last round. We have just 3-4 questions, and I'm sure the students are going to find it easy. GOG score. More than 120 associated with more than 40% risk of recurrence, includes tumor size, LVSI, stromal invasion, both of the above or none of the above. So what is your answer about GOG score? So, yes, again, learning question, GOG, that is the Gynec Oncology Group score. It is based on tumor size, LDSI, stromal invasion. Each is multiplied by a factor. And the score more than 120 is associated with a very high risk of recurrence. Let's look at the next question. So, some shuffling between R. Patnaik and Dipali. Wrong match for targeted therapies is VEGF inhibitor, bevacizumab. I'm so sorry. The PD-L1 receptor answer is pembrolizumab, tyrosine kinase inhibitor, lapatinib, and EGFR inhibitors, cetuximab. So which is a wrong match? And the correct answer was tyrosine kinase inhibitor, lapatinib. Actually, lapatinib is also one of the EGFR inhibitors. All these words sound similar and strange to most of us. But remember, with the leaps and bounds that the medical science is growing, we would soon be dealing with all these molecules in treating our patients. Mallikarjun has a streak with 4 correct answers. AKB continues to lead. The second last question on your screens, a lot of people would know, trial underway based on sentinel lymph node biopsy is Centicol, SHAPE, SACOR, or Outback. Which trial is underway based on sentinel node biopsy? I am actually being selfish and I expect all correct answers here. And the correct answer is Centicol. So Centicol 1, 2 are already complete, 3 is underway, and the results are expected to be out soon. Outback is actually evaluating the need, was based on need for additional adjuvant chemotherapy. And SHAPE was based on outcomes between radical hysterectomy and simple hysterectomy in early stage disease. Let's look at the scores before the final question. AKB looks like is going to walk away unless somebody is fast enough, and Dr. BSR is the highest climber. And the last question, LAC trial showed equal or better survival with minimally invasive radical hysterectomy than open RH. Is this statement true or false about the LAC trial? Already more than half the answers are here. Last 15 seconds to go. And actually, oh, okay. So clearly, perhaps the 19 were not tuned into the case report. Had you been, you would have heard the discussion on LAC trial. So LAC trial was a randomized trial which compared open radical hysterectomy to minimally invasive radical hysterectomy. And there was a clear difference, and open hysterectomy had better overall survival, better disease-free survival, and lower recurrence rates compared to the minimally invasive RH. So that brings us to our podium finish. And let's look at the final scores. At the third position, we have Satvi. Congratulations. At the second finish, we have R. Patnaik. And no prizes for guessing the winner of today's quiz, that is AKB. That brings us to the end of our quiz for the day. And I will just stop sharing.
Yes, Dipti.
Yes, sir.
Thank you very much. Excellent quiz conducted by you. And I was a bit tense when the Archana left to catch a flight. But then you managed it so well and you explained everything so well, so nicely.
Thank you so much, sir.
You are a West Zone coordinator and a good successor of Archana for the next higher rank.
Thank you so much, sir. Last couple of years, we have been regularly conducting quizzes in a lot of programs with Nilesh sir. And Archana madam was really very kind that she trusted me with this opportunity. And I thoroughly enjoyed preparing for this. And really, sir, congratulations. The case discussion, the way the students presented, the level of discussion, the practical points about, right, everything from the parametric assessment, acetic acid, the MRI evaluation, everything was just brilliant. I am sure all the students who were logged in and the teachers, everybody would benefit.
Actually, I mentioned in the closing remarks that the students were postdoctoral training, they are not postgraduates. The postdoctoral, they are doing MCH courses. So naturally, we expected a level higher than what is usually we see in MS examination.
Yes.
In that apart, all the examiners were qualified medical, surgical oncology. So therefore, it has to be. But same thing can be said about the quiz. You worked such a lot, such vigorous mehnat aapne diya hai on this program that it is evident from the organization of the question, answers, explaining them. Remember, it needs accurate studying of each and every component of the stage. So, all kudos to both of you, and particularly you, Deepti. You have done a wonderful job. Thank you very much for the participants, and the congratulations to the winner. And as we already announced, the 3 topmost candidates will receive a book from our chairperson.
I have a query to the technical team. Is there any way that those top 3 names, you can contact them and take their details? Because they are not in our participants list. So from the attendee list.
Yes, ma'am. We'll share the mail ID and number.
All right. Perfect. Sounds good. Thank you so much.
Okay. Thank you so much, Deepti. And I hope that somebody is there in the podium, in the online podium. In absence of anybody else, I would like to thank profusely Deepti and Archana for conducting this quiz. I thank all the faculties associated with this program. Thank you very much for your participation. On behalf of ICOG, I extend my warm and heartfelt thanks to all of you. Thank you very much till we meet in the next program, that is the second Sunday of the month of April 2025. Thank you so much. Thank you.
Yeah, thank you so much, everyone. So from here, I'm